I had to learn a lot to take care of my patient to provide a better care. So then I started searching for some courses or something which can improve my knowledge. I understood just reading the textbooks or articles is not going to help me. So something in a structured way was required for me to achieve that particular level of knowledge. Then one of my colleagues suggested like there is a specialty or a certification exam, and they do have different specialties. And when I looked into, I found like neurology has not been started yet. So the next best specialty for me was a pharmacotherapy, since it included all the diseases. Like if you look into the Dipiro textbook of pharmacotherapy, all the diseases were included in this particular specialty exam. So I thought, okay, I'll just give it a try, and I started learning. And then after 3 years of preparation, I could achieve this particular certification. So, what is BCPS? It stands for Board Certified Pharmacotherapy Specialist, and it is a specialty exam in one particular specialty. It's in the pharmacotherapy. Okay, so there are different specialties where you can do this particular certification, and this certification is provided by the Board of Pharmacy Specialties. So it is called as BPS. So don't confuse yourself with this BPS and BCPS abbreviations. So this organization is the international standard organization who is giving the certification for the clinical pharmacist. It is considered as a gold standard because of the
Oh,
quality they
sorry to
maintain
disturb, ma'am.
throughout this process. So, yeah, please.
Ma'am, actually, I believe the slide is not changing.
Is it visible now?
Yeah, you are visible. Uh, the slides are not visible.
Okay, I'll just. I'm sharing my screen again.
Oh,
Okay, just a minute. I think. Is it visible now?
yes, ma'am. The fifth slide is visible.
Okay. Okay, so I just stopped in between telling about the gold standard and how they are assessing you. So they are looking into the quality of a pharmacist, the level of knowledge you acquire while preparing for the certification, and as well as at the time of this examination, how much knowledge you have gained from your clinical practice. That is what they are going to know from your performance. So after getting this certification, you are qualified for advanced level of practice, and you will have a new perspective and a better approach to your patient care. So that's what they're trying to bring in through this certification exam procedure, and so that you will be staying updated and you will get to know what are the recent advances in the therapeutic management of the patients. So, as I mentioned, there are different specialties in which you can do the certification exam, and on what basis you are going to select a specialty on the area of expertise. Like till time where you're going to start your preparation, where you're practicing. In minimum time, as mentioned in the, will tell how many years of experience is required for you to appear for this particular exam. For example, some specialties will require just 3 years of experience, but few specialties suggest few years is calculated based on how much knowledge you have to gain through your clinical practice. So, depending on your career goal, your interest, the area in which you are practicing, you can decide which specialty to choose from. So, these are the different specialties available: the critical care part, emergency medicine, geriatrics, infectious disease. So many specialties are available till now, and they are trying to bring in new specialties depending on application exam. So, regarding the preparation for certification exam, again, it depends on which specialty you are choosing, how much expertise you have, how long you have been working in that particular specialty, how much you know in that particular area, and depending on your working schedule and how many study hours or how much time you want yourself to prepare. Some may require a very short period of time, like 2 or 3 months to 1 year time. I took almost 3 years of time out of my duty, so it took some time. Minimum of 3 to 6 months is required for your. Require some review courses, because just going through some textbook and learning some theory is not going to help you for what to tell, appearing for this questions, the MCQs which they give, it requires some kind of training. Without answering this MCQ, that requires a special time and preparation. Okay, so just learning the theory alone will not help you, but answering some MCQs for which this review courses are going to help is very much required. Unless you prepare yourself for the MCQ, it's going to be a tough thing, because this exam is not it's like a real life, real patient which you are seeing in front of you. You'll have a situation and you'll be given 4 or 5 choices to choose from, and you may have to choose either one of the best answer or some multiple answers will also be there. So if you look into the options, you can see that 2 or 3 options will feel like 2 or 3 are the same, but out of the 3 options, only one answer is going to be the right one. So choosing the best answer is going to be the toughest decision, and that requires intense training in choosing that particular answer. So MCQ is not that easy as you think, but if you have a good training and if you are prepared well for it, you can do it. So what are the preparatory courses or the review materials available? American College of Clinical Pharmacy and American Society of Health Pharmacists, they are providing some review courses, and they do give some continuing education. They do give theoretical aspects, as well as they provide some webinars regarding how to appear for the exam, how to choose the answers from the multiple choice questions, and how to approach that question. These kind of guidances are given through different webinars from these organizations. And there are other organizations which are providing the resources like High Yield Med Review and Med 101. So I started with ACCP review material, but then I understood that was not sufficient, because my basics were not that good. So I wanted something to start from, to learn from, and I chose HYMR, and given by that particular lecturer, Dr. Anthony Bastai, who did most of the lectures in that particular resource, the concepts in a better way. ACC taught basics, and if you know the theory very well, it's a review course. So it's like it will give you the superficial things from the examination point of view. So the selection of resource again depends on your knowledge. So you can just go through the feedback and other reviews by the people who have passed that particular specialty exam, and then you can choose among these. You can go with one or two. So, what is the content outline? So, each specialty exam has its own division of domains. If you
Ma'am,
look at it again, is it stuck?
ma'am, yeah. From fifth, just it came to 10th slide. Also, your voice is breaking.
Okay, just a minute.
Yeah.
Is my slide visible now? Okay, so again, let me know when it is stuck again. Is it visible? Okay, so in this particular exam, we have three domains. So as you can see, 65% of the examination is covered based on the patient-centered pharmacotherapy, where we'll be learning more about the therapeutic management of each disease. And in the domain 2, you'll be trying to apply the evidence-based practice. So what is the evidence telling you and how you are going to apply those recommendations to a clinical scenario. And domain 3 will be assessing your knowledge in the healthcare systems and the population health, where you will take some preventive measures, how to prevent the future complications of a particular disease, or how you are going to screen the patients for a particular disease so that you can advise them, counsel them, and educate them regarding the disease as well as the medications they have to take. For example, how to maintain the immunization schedule, how the immunization is going to help them from prevention of infections. Uh, these points will be coming under the health domains. So if you can see, which covers mainly the disease portion where you are trying to assess the diagnosis and you are going to start or plan a treatment regimen for a patient, then you will be monitoring the patient, assessing them throughout so that you can know whether the medication or the treatment is the best for the patient, whether they are adequately responding to our treatment plan, whether any modification is required. Like the patient is not responding to that particular medication, whether that medication need to be changed or not, whether any dose has to be increased or decreased. So those and what communication you have to give to the patient. For example, if you're starting a medication, you have to tell the patient what is your goal, what are you trying to expect, or what expectation you have from that particular medication. If you're giving an analgesic, whether you're trying to get full pain relief or is it a 70 to 80 percentage of pain relief. So once you communicate your expectation, the patients they will be ready to face the response and they'll be giving you a good feedback based on how you communicate to the patient. And then educating them regarding the indication, the side effects, the development of complications, and what they have to do in case they have some issue with the medication. Second domain includes the application of evidence to practice and education. So how we are going to um attain or how we are going to get the recommendations or how we are going to get the information from the guidelines and what will be your evaluation, how we are going to assess the critical analysis or the positive analysis of the particular article which is being published. You know, each and every day we have so many new articles and evidences coming for most of the diseases. So staying up to date and utilizing the recommendations properly for the patient. So that particular aspect will be assessed in this domain. And then using that recommendation in your patient in an effective way. Then the third domain includes the healthcare system and population health, where you are going to improve the proper medication usage, utilizing the technology and newer technical advancements for improving the patient care. And then what kind of public health initiatives you can start so that you can improve the population health. And then how to provide safe, effective, and economical use of medications in our population. So it's like instead of a single patient care, how we are going to take care of the population as a whole. So, what are the expectations from a board certified pharmacotherapy specialist? Once you have been certified, you have to take care of the patient, not only the pharmacological medication part, but also you should be very knowledgeable in the non pharmacological therapy also. As you all know, many of us don't like to be on medications on a chronic basis. So we always ask our doctors for what are the non-medical options, the non-pharmacological therapy. For example, some diseases can be managed with physiotherapy, where medications can be avoided, or some patients require some other recreation or some other activities so that they can stay away from the medication. So knowing this non-pharmacological therapy will help you improve the patient care. Likewise, what are the alternate measures or alternate treatment regimens that can be provided to the patient? And as we all learn throughout our course, it's the right drug or the right treatment plan for the patient. How to choose that particular therapeutic regimen for the patient. That is what it's whole expectation. The whole expectation from a BCPS pharmacist is providing the best effective treatment for the patient, including non-pharmacological, pharmacological therapy, utilizing the updated information and working as a
Excuse
team
me,
member.
ma'am.
Yeah,
The
again,
PPT hasn't
sir.
changed. Yeah, now it changed.
Okay. So, working as a team member, we will be working with all the healthcare professionals, including the physicians, the nurses, the dietitians, the physiotherapists. So, how to utilize their knowledge, how to contribute from our side, how to manage the diet and medication, for example. All these aspects will be assessed in in this particular examination. So, it's like an ocean, learning so many diseases, and it's not only the therapy or the drug related information that you have to know, but you should start from the disease till the treatment as well as the monitoring and follow up of that particular patient. So the impact of certification is finally you improve your quality of care. You will have a new perspective towards the patient care, because till now you'll be having some standards of practice, and once you get certified, after getting trained for the certification, of course your standards will be improved, and you'll be standing out of the crowd. Like you'll be having something unique. You are not going to be the same like any other pharmacist or clinical pharmacist, and it's like getting a recognition in that particular specialty. So, how did I prepare for my certification? As I mentioned, I used the ACCP and the HYMR resource, and of course, you have to go through all the updated guidelines. They will mention like if you're taking based on when you're taking the exam. For example, if you're taking it in October, till June or May, what all guidelines have been published that will be utilized for the preparation of examination questions. Because once the guideline is published, it will take some time for implementing it in our practice. So they'll always consider that gap so that you will get to know how the practice is changing. So updating the guidelines and recommendations is very important. And for me, since even though I had a busy working schedule, I had some time for presenting small topics, and I utilized it for my preparation. So whenever I completed one disease or a particular topic, I made it into a PPT and I presented it within my team, and I had some discussions, and all those learning points were applied to my patients. So I utilized it during my clinical rounds so that I could apply it and I could easily memorize it. And whatever I learned regarding the counseling and education for the patients, I started doing it for my patients. So my work, I just included all the learning aspects and I utilized that time for kind of revision. And of course, sharing my knowledge to whoever was in my team regarding the disease or whether it is regarding the medicine, just sharing whatever I learned helped me a lot for preparation of this exam. So I would like to give you some sample questions just to know how they are going to assess you. So basically, it's not, as I mentioned, it's not just the drug information or the pharmacotherapy they are going to assess, but it's all about approach towards the patient. How we are going to make sure whether this is the diagnosis and how we are going to take the treatment regimen starting from the diagnosis till the follow-up. So we'll just go through one question. So this is like a 66-year-old male. He was brought to the emergency department with complaints of loss of consciousness. When he had this issue, he received medical attention within 10 minutes of time. And as per his past medical history, he also had complaints of slurring of speech and right arm weakness almost 30 minutes before the LOC episode. He was on antihypertensive medication for past 2 years. So he has been brought to the hospital. And the question is, which test?
Ma'am, the slide isn't changing.
Okay, is it visible now?
Yeah. Ma'am, could you do
Okay.
one thing? Like, can you click on each and every slide when you're, changing?
Yeah, sure. So is it visible right now?
Yeah, it is.
Okay, so basically I was just telling a question there. Sorry. Okay, so like right now I have clicked slideshow. Is it visible now? No. So okay, if the normal mode is visible for you, I'll continue the same. Is that okay for you?
Yeah, normal mode is visible. Just click on each and every slide because maybe you're clicking on the arrow button and it's moving from your end, but we can't see it.
Okay, fine.
Yeah.
So I'll just try once again with the slideshow. Is it visible now?
No, the slideshow is not visible.
Okay, so I'll continue with the normal mode. Okay.
Yes. Okay. Just click on each
Okay.
and every slide if possible.
Sure. Thank
Yeah.
you. So, a 66-year-old male had a loss of consciousness. He received medical attention within 10 minutes of time and he was brought immediately to the emergency department. And he also had a history of slurring of speech and right sided weakness for about 30 minutes before he had this loss of consciousness. And he's a non hypertensive patient who is on medication for past 2 years. So the question is, which test would be the best before initiating pharmacotherapy? So, anyone would like to answer this particular question? Just give it a try, no issue. I'm going to give you the answer anyway with the reasoning. Do you think an angiogram is required right now, or should we move on with the CT of the brain, or should we go on with a coagulation panel, or should we go for an urgent echocardiogram? Okay, fine. I'll just move on to the answer. Is the slide visible?
Yes, ma'am.
Okay, so the answer is B, that is CT. So it's like, as I mentioned, it's not just a pharmacotherapy, but you should also be knowing or having a good knowledge regarding the diagnostic test used. So here the patient is suffering from a stroke, something going on in his brain, and the first thing to be ruled out is a stroke. And if it is a stroke, you have to give urgent treatment with thrombolysis. So for that, you are supposed to know whether it is a hemorrhagic stroke or an ischemic stroke. So for that particular differentiation, a CT of the brain is very much required. So the answer is CT, and why not the other three? So I have given the reason can be done on a later basis. That is not going to help you in taking a decision on thrombolysis. And a coagulation panel is not required for your thrombolysis decision, as well as this echocardiogram that is also considered as part of a detailed evaluation, which need not be done on an emergency basis. Okay, so among these four options, right now the best option is, or the best answer is, CT of the brain. So I'll give you another question. Is the slide visible? Okay, so this is the second question. This is regarding the pharmacotherapy of a patient. So an 84-year-old male who came with pain from hip osteoarthritis. He has hypertension, coronary artery disease, as well as benign prostatic hyperplasia. So For his osteoarthritis, he has been taking acetaminophen 650 mg thrice daily, and he is reporting that the acetaminophen is helping him, but the pain is persisting and it is limiting his ability to work. So, what next option can be provided to the patient? And these are the choices for you. Anyone want to answer this question? Based on the American Geriatric Society. So, the thing is, from this question, what all are the clues they are giving? First of all, you should look into the patient's age, that is 84-year-old, and the patient has OA, and the first line of choice is NSAID or acetaminophen, which he has been tried. It is giving good response, but an inadequate response has been assessed from his history. So, how to make a change, whether you have to increase it or change the medication, and how to choose the next line of medication. So, considering the geriatric population and the algorithm of treatment, opioids are the best next to the acetaminophen treatment. So, here what you should know is the guidelines, the recommendations for osteoarthritis, what is the treatment algorithm, what is the first choice, what is the second choice, and what are the contraindications. In his case, if you see, they have mentioned like he's already a non-case of coronary artery disease and he also has hypertension. So it's always better to avoid celecoxib and ibuprofen. Or you can take it this way, like if a patient doesn't show any good response to or an inadequate response to acetaminophen, you need not expect a better response from celecoxib or ibuprofen. So it's always better to change to another group of medication, and that lands up in hydrocodone. Glucosamine is also one choice, but it is not going to give you a pain relief, but it's just a supportive treatment. Okay, so just with these two sample questions, I am just winding up the session. So it is open for any questions.
Hello, am I audible?
Yeah.
Yeah. Good evening, ma'am. Angelina Titus here. I'm actually a family intern right now. So, ma'am, I just wanted to know that actually missed the earlier slides because I was in one of the event. So the significance of the board certified program. So if we take it from a board institute, like American Institute, etc. So can we practice abroad with certification?
For practicing abroad, the first and foremost thing you require is a license. So without a license, with the certification exam, I don't think they'll allow you to practice there. So I have not explored that option actually, even though many of them asked me. But I'm sure about one thing: you require a license. So whether it is USA or Canada or any Gulf countries, you require a license, and depending on the license procedure, it will take some time for you. But once you have the license, the certification is going to help you a lot. For example, in Gulf countries, I have seen many hospitals taking clinical pharmacists, and they do have a criteria where they mention like they prefer, you can just pass the license exam in Gulf country, it's very easy for you to get into the practice, and they do pay a very good salary for board certified clinical pharmacists.
What would you suggest? Like, should we do on a specific field of like expertise or a general clinical pharmacy?
Yeah, if you look into this pharmacotherapy, it's like a general clinical pharmacy thing. And because I didn't get an opportunity to do it in the neurology specialty since they are not providing it in that particular area. And my interest, I wanted to refresh my basics, and I wanted to go through what all are the recent advancements in most of these diseases. because even though I am in a neurology specialty, I have been seeing all sorts of cases, because all these diseases will have some kind of neurological complication. So basically, I had to know about these diseases. So I thought first I'll start with the pharmacotherapy, and it gave me a good perspective, especially the patients are coming with diabetes, hypertension, kidney impairment, heart failure, so many cardiology issues, and a collection of comorbidities. How to choose a medication based on these multiple disease condition, and how to treat those patients, how to provide them a better therapeutic regimen. This preparation for this exam helped me a lot, and now I can see the difference in my practice. Initially, what I used to do, and how much I had this fear to approach a patient to take a decision for that particular case. Now I'm able to discuss it with my physician. I'm able to communicate it to my patients, and I'm just happy and confident enough to have a good discussion with them. If you don't know, just express it yourself, because um, you have developed a capability to look into the evidence-based medicine. So you can always tell your patient, right now I don't know what will be the best treatment for you, but if you can give me a 1 or 2 days time, I can get back to you with the latest advances or the recent updates in your disease and treatment. So it will help you a lot in many ways. And selecting the specialty, of course, it depends on which area you are practicing right now, or in which area you want to improve your knowledge. Okay,
Thank you very much.
thank you. So a few points which I didn't mention in the slide is like, directly after the PharmD course, of course, you won't be able to appear for this exam, but that doesn't mean you should not start preparing for it. Even from your internship, we can start learning, start going through the disease, the diagnostic test, just refresh the pathophysiology behind each and every disease. What are the pharmacotherapy options? Make sure that you're thorough with the pharmacological classifications. Most of the time, the difficulty I find in the internship students, myself, when I was doing my internship, I was not very confident in telling the pharmacological classification. Even now, I have difficulty in recognizing the medication. At least if you know what medication it is, or at least one indication for that medication, it will be nice. Without knowing the medication name or what it is being used for, it's going to be difficult for you to interact with the patient. So at least make sure that you know the basics, at least the pharmacological classification, the major adverse events, the important monitoring parameters, what to follow up with the case, what are the goals of therapy for each disease. These are the basic things you can learn at this point of time. As an intern student, I hope so many intern students are participating in this particular session. So utilize your time and know the disease well. Daily, on a daily basis or on a weekly basis, just learn 2 or 3 diseases. So at the end of your internship,
coming up, and it's a very growing field. You think it is difficult, but with practice, it's very easy and very interesting, because every day is a new learning in oncology. Every day, something new, you will be observing it lively. And it's very damn interesting if you start walking through that journey. And I know it initially is very difficult and it was not easy for me too. But it's very easy when you learn it and put your interest. Okay, guys. Thank you. Have a good day. See you. Thank you, Jasmine. And thank you all.
Ma'am. So much.
Okay.
Guys, you can stay in the session. I'll just contact you as the judge, as the speaker comes. Okay. For the next 5 minutes, you stay in the meeting. so sorry for the inconvenience, guys. Dr. Shailza won't be able to take any session right now, as she's having some network difficulty. So because of this reason, we'll meet at 7 for Dr. Anita's session, which is on BPS certification. So any further details about Dr. Shailza's session will be discussed there. Okay, and it will be conveyed to you guys. Thank you so much. We'll meet at 7 again. Is it, cool with you guys? Can you give me a thumbs up? Okay, great. Thank you so much. We'll meet at 7 p.m. again.
From SA node to AV node, the spinning part takes around 0.1 second, and then these waves or impulses or signals are collected by atrioventricular node. Why it is atrioventricular node? Because that is situated or located at the point where the atrium and ventricles are connected. Okay, where atrium, this is the atrium and this is the right ventricle. So they are connected here. Okay, they are connected at this part. This is the wall of, this is the septum of atrium and ventricle. Okay, so in this septum only atrioventricular node is situated. So when these signals comes, they take around 0.1 second, okay, 10 millisecond, and it was here received by AV node. Okay, now AV node process these signals. Okay, again, it takes around 0.1 to 0.2 seconds in the processing of these signals, and then this AV node transmit these signals to here, AV bundle. Okay, this is called AV bundle. Okay, this is called AV bundle. AV bundle means the atrioventricular node has a pure system of the wires. Okay, wires means the fibers, the cells. Okay, fibrotic cells. These are the fibrotic cells, also known as nerves. We call them nerves or fibrotic cells. So these fiber cells are collecting these signals from AV node and carrying to the further part of the heart. Okay, further part of the heart means here, this is the septum between two ventricles, left ventricle and right ventricle. This is right ventricle. Okay, this is left ventricle. So signals are received from AV node now and carrying to the AV bundles. Okay, so bundles means nothing but the bundle of cells. Like you must have seen the the big cables which are carrying the electricity, right? So there is not only one wire, there are multiple wires collected, and then they are making the the entire the big wire, right? They are making the big wire. Smallest wires are collected and combined and making the big wire. Similarly, these bundle is the fiber. Here there are the cells which are making this bundle, and this bundle is carrying all the signals and impulses. And this bundle is distributed into two major parts, two major branches. One is left bundle, okay, and one is right bundle. So the left bundle is carrying the signals or impulses to the left side, and right bundle is carrying the signals or impulses to the right heart. So based on the activity only, based on the signals only, depending on the signals only, these chambers contract or relax, right? These chambers contract or relax. So after this bundle branches, there is the last part, that is the specific fibers. These bundles are now distributed. This bundle is now opened, and every wire is going to the left or right side. These are distributed to the small septal parts. So this is the heart wall, this is the right heart wall, this is the left heart wall, also known as ventricular septum, because this is the septum, this is the wall of left ventricle, this is the wall of right ventricle, right? So this is also known as ventricular septum, here in between, and wall or heart wall also. So these left side Purkinje's fibers are getting the signals and distributing those signals to the left heart wall, left ventricular wall. Okay, and the right Purkinje's fibers are carrying these signals and distributing in the right heart wall or right ventricular wall, right? So this is the major part, SA node to AV node, and AV node to bundle branches, two bundle branches, two branches major, like one is right, one is left, and then left side has its own left Purkinje's fibers, right side has its own right side Purkinje's fiber. So these Purkinje's fibers only helps in either contraction or relaxation of the heart wall or the ventricles. Understand? So I hope cardiac conduction system till here you understood. Now let's see here. Let's one by one. So sinoatrial node, as I told you, is controlled by ANS. So it is like totally, it is as I told you, this is the pacemaker of heart. Okay, coordinates the heart contractions. So located in the upper wall of the right atrium, it generates nerve impulses that travels throughout the heart wall, causing both atria to contract, and then your autonomic nervous system controls how fast or slow your SA node sends the electronic signals. Why electric signals? The speed, because this part of the nervous system directs the hormones that control your heart rate. So as I told you, for example, if you are sleeping or if you are exercising, the heart rate will be different, because the intensity of the SA node will be controlled by ANS. Okay, and the ANS is controlled by the the hormones secreted by the parathyroid. Okay, so that's how it goes. So here the autonomic nervous system includes your sympathetic nervous system. So definitely flight or flight response make your SA node work faster. And parasympathetic nervous system, it is kind of digest response or the rest response, so it makes your SA node work slower. So these are the two ANSs. The symptomatic and sympathetic or parasympathetic nervous systems are helping. So sympathetic nervous system to make it faster, parasympathetic nervous system to make it slower. Okay, atrioventricular node, it is at the triangle of Koch. So as I told you, that that location between the septum of atrium and the right ventricular, there is the septum, okay, that is also contributing to the left ventricle, right? So the septum between left ventricle, right ventricle, and right atrium and right ventricle, so there is a triangle. There is a triangle, and the triangle is known as triangle of Koch. So as this AV node is situated here. So if we see that, let's see here, this is the triangle, this is the Koch's triangle. Okay, this is the Koch's triangle. Why this is Koch's triangle? Because this is connected, this septum is involving for all three: left ventricle, right atrium, and right ventricle. Okay, all three chambers are sharing this septum. So this septum is known as, this point is known as triangle of Koch. Okay, because it was founded by the Koch. So that's why we call it triangle of Koch, and AV node is situated here only, right? So AV node, so when the impulse is generated from SA node reaches the AV node, and they delayed for about 1/10 of a second, as I told you, 0.1 second. Okay, the delay ensures. So okay, why this delay is, see, when the blood comes from the vena cava, it comes to the right atrium. Okay, and right atrium takes time to get emptying into the right ventricle. So this delay of 0.1 second, ensures that the entire right atrium is empty now. Okay, the entire blood has gone to the right ventricle. Okay, that's why it is. So it ensures the empty of the blood before contraction stops, right? Now, the bundles. So bundles are just the branches of fibers which extends to the AV node. This is like, there are major two bundle branches. One is left bundle branch, one is right bundle branch. Okay, so when we must have seen that there are many patients who are coming up with the presentation of heart attack, of heart attacks, and if it is right, then it's minor case. Okay, so what happens? Block means what? Branch block means what? Block, see, when we talk about the coronary arteries, block means the plaque, right? But when we talk about the bundle branch blocks, that means there is a breakage. There is a breakage, or there is a damage of the nervous system. That nerve system, there is a damage in the branches or the fibers of that bundle, whether it is left or right. So that stops the conduction system, or that restricts the conduction system of these signals, or these impulses, and these impulses are not going to either left side or right side. So these are causing, these are restricting the contraction of that system, right? Either the left ventricle or the right ventricle. So that's why the either MI or the right heart failure or the left heart failure, it happens. This is the major pathology when it comes with the bundle branch blocks. So bundle branch blocks are exactly not blocked, but these are the damage of that conduction system, damage of the branches, damage of the fiber here, breakage of the fiber. Okay, then these are the Purkinje's fibers. Again, the extension of the bundles. Extension of the bundles here, individual fiber goes to the different cells or different part of the heart wall, whether it is right side or left side, right? Now look at the system. This is the entire system as we've defined here. Sinoatrial node, this is generating the impulses and spinning in the atriums. Okay, spinning in the atriums and then collected by the AV node, and then going to the branches, bundle branches, left bundle branch, right bundle branch. So this is right bundle branch, left bundle branch, and these are the Purkinje's fibers which are distributing these signals to the heart wall. Okay, understand guys? Clear here? Now see the same system as I told you, it from sinoatrial node to AV, then right and left. Now how it exactly works, how exactly the heart beats. So first, I mean, I have described this also. So first step is the pacemaker, means your SA node is impulsing, generating the impulses or the signals. Then, AV node is getting those and processing those, and then going to the, in step 3, bundle impulses conduction, and then the fourth step is Purkinje's fiber impulse conduction. Impulse conduction means the impulse distribution, and it can be influenced by various factors like exercises, temperature, endocrine system hormones like thyroids and all. These badly influence the cardiac conduction system, and they can cause the arrhythmias as well. Usually these are the responsible factors for arrhythmias as well, right? So here the major part is here. We have to understand that how exactly the impulses work in the cell, how exactly the depolarization and repolarization work, how exactly the contraction and relaxation work, that we will see from here. So ECG has multiple waveforms. Those waveforms we will understand. Before that, we will understand what happens inside and outside the cell, and how the contraction, how it contracts and how it relaxes, right? So we call it myocardial action potential curve. Okay, this is myocardial action potential curve, and this has the phases. This is phase 0, this is phase 1, this is phase 2, this is phase 3, this is phase 4. There are 5 phases, including phase 0 to phase 4, and the entire time is around 200 2 seconds. Okay, entire time here for one action potential curve is 2 seconds. Okay, so let's understand it one by one. So myocardial action potential curve reflects the action potential, which describes the electrical activity of 5 phases. So why it is myocardial action potential curve? Because it is including, or this action potential curve is happening in the muscle of the heart wall. Okay, the cell of the cardiac or the heart. So heart cells are, or heart muscles are known as myocytes. Okay, so it is talking about one cell. So it starts with the phase 0. Phase 0 is called, so you must have heard of that, balancing the homeostatic. Okay, homeostatic balance. So how it enters with the ionic. So always when we talk about the homeostatic balance, it always starts with the ions, because ions are only balancing the action potential, and ions are balancing the homeostatic phase inside the cell and outside the cell. Okay, that's how they contract and relax. So in first phase, what happens? The first phase, also known as rapid depolarization, because usually what happens inside the cell, there is a balance of sodium and potassium. Usually the sodium is at a higher concentration and potassium is at a little lower concentration, okay, inside the cell, okay, with the chloride as well. So we are talking about, we are just positive ions, not much. Okay, in the cells, negative ions does not affect much, so we usually talk about the positive ions. Either these are sodium, potassium, or calcium. So when we are talking about the homeostatic balance inside the cell, so it is majorly parted by sodium and potassium. So how the rapid repolarization happens? Usually what happens when lot of sodium suddenly enters into the cell. Okay, lot of sodium again enters to the cell. There is a balance, but still lot of sodium enters to the cell suddenly. Okay, and that is called rapid depolarization. Why it is rapid depolarization? I'll come to that. So when the sodium goes inside, the potassium starts coming out, because they have to make the balance of positive ions inside, right? There was a balance between sodium and potassium, but now the extra sodium is going in, so the potassium has to come out. Whether the balance is imbalanced now, or whether the things are going opposite, but the potassium has to come out when the sodium is going inside the cell to make that, to balance that homeostatic inside the cell, right? So this is called rapid depolarization. Rapid, why it is rapid depolarization? Because lot of sodium enters at a time. Okay, it is not slow, it is just a rapid process. And depolarization because the major ion, which is potassium, okay, I mean the numbers, if we look at the the level, definitely sodium is the cell potassium, we can say there is no percentage actually, but usually it is 70-30, like 70% of the sodium and then the 30% the potassium inside the cell. If we talk about the the positive ions, okay, in positive ions 70% sodium, 30% potassium. But still, when rapidly sodium goes inside, the cells go into the depolarization. The muscles go into the depolarization because the concentration of sodium is now very high and potassium goes suddenly down, right? Then again the phase 1 start after the milliseconds. After the milliseconds, as you can see in this curve also, this phase 0 is very sudden. Okay, there is no plateau. This is very sudden. Very sudden means this is just 1 to 2 milliseconds where the entire sodium goes inside and it leaves what we say, throw the potassium out. So immediately the phase 1 starts. Phase 1 is means early rapid repolarization. Early rapid repolarization means potassium has to come out now. Potassium is coming out. Then what happens when the potassium comes out? Lot of sodium is inside. Again, the homeostatic is imbalanced now inside the cell. So to that, there are the differences of ions. So to balance that, suddenly calcium enters. Okay, calcium enters to balance that because sodium has to sodium is too much now, potassium is out, so suddenly calcium enters to balance that homeostatic. Okay, and that phase is called plateau. Plateau means here now the things also are coming to the balance. But this is also not for the very much time. This is also for kind of 0.5 to 0.6 second. Okay, 0.5 to 0.6 second, but this is known as plateau, the balance. So this is the cycle. Okay, this is the cycle. This is the major phase. This is the longest phase of the action potential. Okay, the plateau phase. So in this, calcium goes inside. When the calcium goes inside, entire potassium is pumped out. Okay, entire potassium is pumped out. There is no potassium right now in the cell. Okay, the remaining 5-10% potassium also comes out because now calcium is inside. Now there is no potassium at all inside the cell. Then what happens? Potassium started going inside. Potassium starts going inside, and then sodium and calcium starts coming out. That is called depolarization again. Okay, depolarization again means majority of the positive ions are coming out. Okay, this might be confusing. This might be a little tough to understand for all of you, but it is the major action potential what actually happens in the cell, and based on that only relaxation and contraction happens. Depolarization means the relaxation, and repolarization means the contraction. Okay, so usually here any problem here, any question, guys? If you have, please clarify now. Other than that, then we'll jump to ECG and we will understand that here. Okay, that repolarization we will understand here. So here, see, depolarization, contraction, because positive ions are coming out. Okay, and repolarization again means goes to the relax. For repolarization, R for relaxation, D is depolarization, and contraction. Any questions here, guys? No? Okay, that is okay. If you have any questions later, you can ask me. So now let's come to the ECG. So ECG is nothing but the instrument which captures, these signals from your body surface. Okay, so see, there is a very high intensity. There is a very high intensity of these signals inside the heart wall, like in the septums. But there is a certain intensity of these impulses which comes to the entire body, and that can be captured at your skin, that can be captured at your body, different centers, different sites. So I mean, it is everywhere, but the scientists have they have found some specific certain places from where they get the exact impulses, they get the exact intensity of those signals, and they can use those signals to, and based on those waveforms they can diagnose the problems. Okay, so that entire system is called ECG, electrocardiogram, or like ECG or EKG. Okay, so In Romans, in Greek, that was electrocardiogram, KARDiogram. Okay, so this is the record of the electric signals from heart to check for different conditions, and electrodes are placed, as I told you, at the certain sites, and then these are captured and turned into, or the translates into the waveforms. Okay, translates into the waveforms, and that waveform you can get print, or you can check in the monitor, you can check in the computer, and that can be what we say interpreted easily to diagnose the heart problems, right? So this is definitely the painless and non-invasive way to help diagnosis many heart problems. A healthcare provider might use an electrocardiogram to determine or detect the few things. First, the major part where we use the ECG is arrhythmias, right? So arrhythmias is nothing but either slow heart, high heart rate, and that could be because of the normal conditions also, that could be because of the typical conditions also, that could be because of the complexation, or the complex blocks in the conduction system, that could be because of the injuries also, that could be because of the surgeries also, that could be because of the toxins, or I mean there are many there could be many reasons which can cause arrhythmias, right? So tachyarrhythmias, bradyarrhythmias, there are two types of arrhythmias. So we usually use the ECG majorly in testing or diagnosing arrhythmias, right? Irregular heart rhythms. Then we check the coronary artery disease by this ECG. So when the patient gets the myocardial infarction, again this conduction system is affected. Okay, so it shows us that which part of the heart is affected, which part of the heart got the injury, because that injury also is there in, it reflects in your conduction system also. It reflects in the like which part of the heart is having that injury, and whether it is foot fiber level, mid, whether it's in the apex, whether it's in the anterior part or lateral part. So the conduction system shows that part also. By that we can diagnose coronary artery disease, right? So there are multiple types of MIs, anterior wall MI, lateral wall MI, anterior-lateral wall MI. So that can be easily diagnosed with the ECG. Okay, and if we talk about the the typical types of MIs like stable angina, unstable angina, and STEMI. So we can check with the waveforms also whether there is a STEMI, whether like non-ST elevations or ST elevation MI. So those things can be easily checked by the ECG waveforms, right? And definitely, if we have the previous heart attacks, we can check it out by ECG. And if we are, if the okay, somebody is speaking. Anyone have any question here? Guys, anyone have any question?
No, sir. Carry on.
So these conditions can be checked by ECG easily. Okay, and then if the patient has gone through any kind of treatment earlier, like pacemakers, and if they are function with ICTs or CRTs, this cardiac resynchronization therapies, so that also can be checked by ECG. Their rhythms, their functions, their correct functions, or their abnormalities also can be checked by ECG, right? So this is the normal electrocardiogram. So let's see. Okay, so usually one waveform, as I told, one waveform reflects one entire action potential curve. Okay, look at this. It starts from the P. Okay, it starts from the P. So first point is called as P. Okay, and that is showing the phase 0. Okay, that is showing the phase 0, the P wave. Okay, and then it goes to the QRS complex. Okay, phase 1, and from that in the phase 1, phase 2, early depolarization, and the early depolarization can be seen here, and it makes the entire QRS complex. Okay, so it is here we are seeing the normal P wave, and then after P wave, the Q, and then R wave, then the S wave, which is inverted. Inverted means it is going down. Okay, R is going upward, and then Q is going downward. So it is showing the rapid depolarization and repolarization complexation here. Okay, this is showing the repolarization and depolarization complexation. I'll explain the next slide, but here let's check out the waves. Okay, so the first wave is P wave, then it is Q wave, which is inverted. Inverted means going down. Upward means it is going it is going upward, so that is R wave. Again, S is going downward, or we call it inverted, and then it comes up. This is the balance line. Okay, so this flat line is the balance line. If we check out, this is the flat line. Okay, and then it comes, or the one cycle ends with the T wave. Okay, the T wave is also upward, right? So usually, for an example here, like if there is a heart attack, if there is myocardial infarction, and there is, as I was talking about, an STEMI or STEMI. Right? So what is STEMI? Like it is ST elevation MI. So here this ST, gap between S and T, this gap will not be straight. This will be elevated. Okay, so here it will be like this. Okay, it will be like this. Non-ST elevations, what happens usually in non-ST elevations? It goes downward like this. The ST is like this. Okay, ST is like this, inverted. Okay, so, and when we talk about arrhythmias, this entire QRS, see, now QRS looks normal, it is 0.01. Okay, it is 0.01 second, 0.01 to 0.03 seconds. Usually, normally it is 0.03 second. So there are two types of arrhythmias. One is broad QRS, one is small QRS. Okay, so narrow QRS actually. Okay, so narrow QRS arrhythmias and broad QRS arrhythmias. So this you can see, if it is a broad QRS arrhythmia, this will be starting, the Q will be starting from here, somewhere here, then R, then S, like this. This is broad QRS. Okay, this is broad QRS. If it is narrow QRS, means this Q will not be here, even it will be here, Q or S, immediate. Okay, immediate. So that kind of things are narrow QRS. And broad QRS means this waveform, this R will have a lot of gap like this. Okay, so we'll check out that, but this is a normal ECG. This is the normal ECG one conduction system from P to T. Okay, so P, and the gap between P and R is called PR interval. The between S and T called ST interval. This entire Q or S is called QRS complex. Then this is also ST interval, ST segment, ST interval. Here PR segment, because this segment is flat. Okay, the flat part is also known as is always known as segment, and the entire part, starting one wave, one end of the same wave, or till the start of the next wave. Okay, it's called as interval. So this P to R. Okay, this is called PR interval. This PR segment, because this is starting from the end, and this is the flattened part. Flattened part is always known as segment. Okay, flattened part of any wave is called as segment. So this is PR segment. This entire section is PR interval. This is QRS complex, because this is there is no flattened part. Okay, and then here this is ST interval from S2 at the end of the T, and this is like the flattened part is ST segment, and this is TP segment, because there is a gap, certain delays which takes place before starting the new wave, or before starting new action potential curve. Okay, so let's go to this part now. Let's understand this. So as that we have seen PR segments and all. So P wave is actually the atrial depolarization. Okay, P wave is the actual depolarization, means contraction. As I told you in that slide also, R relaxation, D for contraction. I mean R, whenever it is repolarization, it is relaxation. Okay, whenever it is depolarization, it is contraction. So the phase 0 atrial depolarization, contraction. Okay, then this QRS complex is ventricular depolarization, means ventricle contraction. Okay, and then this ST segment is ventricular repolarization, means the relaxation, and it takes time and it delays the process for more than 0.1 second so then the next action potential can start after relaxation. So let's understand in the normal scenario, let's understand in the heart. When the blood comes into the right atrium, it is suddenly depolarized. It is suddenly the depolarization, and it contracts. The left atrium contracts and sends the blood to the left ventricle, left ventricle. And that segment phase, they told you the delay of 0.1 second. Okay, that delay of 1.1 second is again here. You can see atrial ventricular depolarization. So the entire atrium is now empty. Okay, and complete blood is in the ventricle. So now this time, this action potential takes time. Okay, action potential delays for let's reconnect with the calcium. The plateau. This phase is called plateau phase, where the blood goes to the pulmonary arteries. Okay, and the next phase start. Next phase means the blood has gone, but there is certain blood which is coming back to the left atrium, right? So that is ventricular depolarization. Ventricular depolarization means here left ventricle. So the blood which was there already in the left ventricle goes out to the body, goes out to the aorta, and the atrium, which is filled with the pure blood which has come from the lungs, will start coming to the ventricle. So that is also the depolarization, and again the blood will come to the ventricles, and by the time the ventricles will be relaxed, because the blood which was existing has go back, has pumped out, has gone to the aorta, and now the blood is coming from atrium to ventricle. So that part is known as ventricular repolarization, which is beginning, and then the complete ventricular repolarization happens, and then it starts with the new cycle. It starts with the new potential curve, and then again same, the blood goes from the left ventricle. So it takes the time. Okay, that is the entire ECG physiology usually. Okay, so ECG is one of the most useful investigations, as we know. So there are the limbs, there are the, what we say, there are the attachments, voltage changes which can be captured through our skin, right? So there are the leads. Okay, there are the leads which are attached to the different segments of our body, different specific spaces, specific points where these leads are attached, right? So my question here is, for a 12 lead ECG, okay, before that question, tell me how many leads, how many types of ECGs are existing based on the leads? How many types of ECGs based on the number of leads, guys? Tell me, how many types of ECGs have you seen based on the number of leads? Like suppose we always talk about 12 lead ECG. This is the 12 lead ECG. 4 types. Can you write, Rajni's, 4 types of leads? Please guys, tell me how many types of leads based on the number of leads. Type, guys, please. This is very basic. You must have seen in the words, or when you're going to check. Basis of color, there are leads. I'm talking about the types of ECG strips come out, or type of ECG machines. There are types of ECG machines based on the leads, number of leads. 6 lead ECG, 12 lead ECG, Tausif Atar. Okay. Anyone else? Okay, so this entire chapter is very new for you guys. 7? No. 16? Come on, guys. Extreme, you're going extreme. 12 lead ECG is written here. Here, this is 12 lead ECG. These are leads, Angelina. V1 to 6 AVR. These are leads. Number of leads, based on number of leads, how many types of ECG are existing. Okay, leave it. You guys don't know. Okay. So there are 3 types of ECGs based on the number of leads. Okay. One is 3 lead ECG, one is 5 lead ECG, and one is 12 lead ECG. Okay. One is 3 lead ECG, one is 5 lead ECG, and one is 12 lead ECG. Got my point? Note down this. 3 lead ECG, 12 lead ECG, and 5 lead ECG. So 3 lead ECGs are portable machines. Okay, portable means very small machines that you can connect with the patient anywhere. You don't need the the entire system of attachment, entire leads to attach to the body. Okay, you just need 3 small leads you attach to the chest, and you can get the entire ECG. Okay, that will be transmitted to the ECG strips. So those are called 3 leads ECG. Okay, those ECGs are usually the portable, which you can keep in your pocket also, and you can carry to the remote areas or to the camps and other things, because the entire ECG machine is really tough sometimes to carry to the the camps or to the remote areas. When the people travel, when the doctors travel, when the the ECG technicians travel, so they keep either three strip, what we say, the 3 lead ECG or 5 lead ECG. Okay, so let me tell you, 3 lead ECG means there are 3 leads to attach to the body. 5 lead ECG means there are 5 leads to attach to the body. Okay. And now tell me, how many leads will be there in the 12 lead ECG to attach to the body? Guys, 3 lead ECG has 3 leads. 12 lead ECG, 5 lead ECG has 5 leads. So how many leads will be there in the 12 lead ECG? 12 leads, Dharmendra Purohit. Okay. Sorry, 12. Anyone else who wants to give a try? All wrong. Okay. So 12 lead ECG usually have 10 actual leads to attach to the body. Okay. 10 leads. Let's see. So that is the basic things we must know here. So the leads means actually the electrodes. Okay. Electrode means the points from where we collect the impulses and change that machine will change them into the waveform. Understand? So 3 lead ECG has 3 electrodes, 5 lead ECG has 5 electrodes, and 12 lead ECG has only 10 electrodes to attach to the body. Okay, only 10 electrodes. Now, can you tell me how the ECG looks like, how these different types of ECG looks like? Do you think there will be only as I told you, there are usually 12 waveforms, 12 types of the wave combinations in the ECG strip? So what do you think? How many type of waveforms or wave combinations will be in the ECG strip with 3 lead ECG, and how many waveforms in 5 lead ECG, and how many waveform combinations in the 12 lead ECG? Can you tell me, someone? Did you ever see the 12 lead ECG? I think you all must have seen the 12 lead ECG. Usually ECG machine nahi, ECG strip. Yes guys, have you seen the 12 lead ECG ever? Definitely yes. 3 lead ECG, 5 lead ECG. Okay, so let's explain one by one so you can understand the real difference. 12 lead ECG. Okay, so usually look at this. This is a 12 lead ECG. So there is one combination of the waveforms. Okay, this is called AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. There are 1, 2, 3, 4, 5, 6, 7, 8, 9, 12, 10, 11, 12. So these 12 are the waveform combinations are the printed on the ECG strip to diagnose the problems. How it is? These are the impulses which were available on your body, on your skin, and those waveforms are converted into these 12 combination waveforms. Okay, and here these are also known as bipolar and unipolar leads. Okay, see, these 12 are the combinations known as the leads, which were known as the electrodes. So 3 lead ECG has 3 electrodes, 5 lead ECG has 5 electrodes, 12 lead ECG has 12 electrodes. Okay, but if you think that 3 lead ECG has 3 impulses, then let me show you. This is the 3 lead ECG. Okay, I'll explain that. If you check the 5 lead ECG, it is having the 5 impulses combinations. Okay, 5 impulses combinations. But remember this, all the, whether this is 3 lead, 12 lead or 5 lead, they all will develop at the end all the 12 types of waveform combinations. Okay, strip will, what the strip will you see, that will show only 3 rows of the ECG print, only 3 rows if it is 3 way 3 lead ECG. But the combinations will be all, there will be all combinations, all 12 combinations. If it is a 5 lead ECG, there will be all 12 combinations, but leads will be 5. Okay, and if it is a 12 lead ECG, there will be 12 all combinations, but the ECG strip which you will be seeing will have all 12 in one. Okay, these all will be running in one only, right? As you can see, this is a 5 lead ECG. Okay, as I'll explain one by then you will understand easily. Okay, so let's start with 12 ECG. I mean, this is just to show and where these leads are placed. Okay, so if we talk about 3 lead ECG, there are only 3 electrodes. Okay, there are only 3 electrodes. So one electrode will be at right arm, one electrode will be at left arm, one electrode will be at left leg. Okay, in the 3 electrodes, in the 3 electrode ECG or the 3 lead ECG, the placement will be right arm. Okay, I mean right arm, left arm, and your left leg. Why left leg? Because usually what we notice is that the impulses, okay, the intensity of the impulses is in the right side more than the left side. That is the card. Okay. I think someone's mic was off on. Okay. So we always, I mean, it is the natural thing that if the heart is generating the impulses, if the SA node is generating the impulses, that means it is generated from the heart, and more impulses, the intensity of the impulses is more in the left side than the right side. So we keep the third lead also in the left side, that is left leg. So right arm, left leg, that is 3 lead ECG or 3 electrode ECG. When we talk about 5 electrode ECG, right arm, right leg, left arm, left leg, and one in the central chest over sternum here. Okay, here over sternum, that is called equivalent lead. Equivalent lead. So equivalent lead means that should be in the center of all 4 leads. Okay, so the signal distribution, usually why we keep it at the sternum, at the central sternum, central chest sternum, because we always believe that is the equivalent lead, and that will be showing the equal impulses which are generated and distributing to other 4 leads like left leg, left arm, right leg, right arm, right? So that the 5th lead is always known as the equivalent lead. Okay, equivalent lead, and that is always placed in the central chest or over sternum, right? And other 6 leads are on the ICS, on the chest only. So one is page, right? 4th ICS, like what is ICS here, guys? Intercostal space. Okay, intercostal space. So 4th intercostal space, 5th intercostal space, and one is between the V2 and 4. Okay, so let's check here. So this is the color. This is the color combination. So always when you see the ECG leads, white is always placed in the right arm, red is always placed in the left leg, or if we talk about arms only, then right, white, black, left side, left arm, then red, left leg, green, right leg, brown, central chest. Okay. Again, if it is, if we talk about the right side, if we talk about the right chest, we keep always red. Okay. And then external edge, the left side, yellow, and the green between B2, B4, that we'll see here. Okay. In the next slide. So these are the actual leads. These are the color of your, the electrodes, right? So these 6 leads are for your chest. These six electrodes are for your chest, and these are for your arms. I mean your peripheries, 2 for arm and 2 for your legs. Okay. So here we just attach. These are attached with the help of the certain liquid that is also called known as the lubricant. Okay, so these are the 10 lead. In the 12 lead ECG, there are 10 electrodes. So look at this. These are your ribs. These are your ribs, and this is intercostal spaces between the ribs. Intercostal spaces, first intercostal space, second intercostal space, third intercostal space, fourth intercostal space, fifth intercostal space, sixth intercostal space, right? And this is mid-sternum. This is mid-sternum. If we look at this is mid-sternum, and if we talk about left side only, if we talk about left side only, I mean left and right, both, if we divide this part is divided like the middle of the left heart, middle of the left part or middle of the heart is mid-clavicular line. And if we go more left from that, then it comes anterior axillary line and mid-axillary line. Okay, from the horizontal vertical, I mean the horizontal side, if we see, there are the things. So these are the lines, these are the angles of the body, and these are the angles or the spaces. Okay, so these all actually are placed between 4th and 5th intercostals. Okay, these all leads are placed in the 5th between costal space, and these are the lead name V4, V5, V6, what we usually see in the ECG. Okay, so look at this. Now placement. This is RA. This is LA. I mean right arm, right leg, left leg, and then V1 is placed here, V2 is placed here, the apex of the heart and parallel to apex of the heart at right side. Okay, in the right side, apex parallel to apex of the heart. Okay, this is apex of the heart. This is parallel to apex of the heart in the right side. So V1 will be here, V2 will be here, then V3 will be at the 4th ICS, and then it goes to the 5th and 6th ICS. Okay, between 4 and 5th ICS actually. So these all three are placed, V4, V5, V6 are placed on the marginal side of the heart, and between the ribs, these two ribs, the 4th, actually on the actually between the 4th and 5th intercostal space. Okay, actually in the between the 4th and 5th intercostal space. So these are actually at the parallel sides. Okay, so this is called clavicular side, and this is known axillary. This is called marginal axillary. Okay, this is V5 is at marginal axillary. This is at mid axillary. This is at mid clavicular. So mid clavicular means the mid of the heart usually. Okay, this is 3rd intercostal. This is 4th intercostal, and these three are between the V4. I mean the V4, V5, and V6 are at the in between the 4th intercostal and 5th intercostal space in the left side, and only V1 is at the parallel to apex of the heart where V2 is placed. Okay, so I hope it's not confusing. See, RA is right arm, LA is left arm, RL is right, LL is left leg. Then let's keep V2. V2 let's keep at the apex of the heart. Apex of the heart, usually it comes at the intercostal space 3. Okay, intercostal space 3, ICS 3. Okay, so intercostal space 3 keep V2, and then parallel to V2 in the right side keep V1. Okay, and after that come to the intercostal space 4, keep your V3. V3 is the lead name. Okay, intercostal 4, keep V3, and then between intercostal space 4 and 5, all three V5, V4, V6 keep the parallel. Okay, so V4 will be a little little left to the V3, and it should be at the mid clavicular line of the heart, right? The mid of the heart. If you if you intersect the heart vertically, then you will see this is the mid of heart, and that is called as mid clavicular line, and you can keep this V4 there. Okay, and then parallel to that, mid axillary is V6 and marginal axillary is V5, but these three are parallel between intercostal space 4 and 5. Okay, this is the lead placement of your things, right? Lead placements of your ECG leads, right? So if you check here, okay, so I was talking about this. So between 4th and 5th intercostal space, V4, V5, V6. Okay, and here will be your V3, here will be your V2, and this side it will be V1 here. Okay, so I hope you understand this now. Now the 3-lead ECG. So 3-lead ECGs, there are 3 leads, and 3 leads are placed like this: right arm, left arm, and LL. So this is not exactly on the arms. Okay, this is not at the arms, are at the first intercostal space from where the arms are actually starting here. Okay, see here, from here these arms are starting, so we keep here. One is at the left side, one is at the right side. So right arm, left arm, and then LL on the leg or at the end of our intercostal space or at the end of our ribs. Okay, that is called left leg. So 3-lead ECG electrodes and kept like this: RA, LA, and LL. Okay, so here we can see this. Use electrodes RA, LA, L, and monitor displays the bipolar leads. Okay, so bipolar leads, why it is bipolar lead? If you looked at the ECG, there are some leads like 1, 2, 3, AVF, AVR, okay, AVL, and then V4, V1, V2, V3, V4, V6, right? So there are some bipolar leads, there are some unipolar leads. So unipolar leads, let's understand the difference. Why we call them bipolar and unipolar. So unipolar leads are not disturbed by other leads. They have their own signals. Okay, they have their own different type of signals. Okay, so like if we talk about AVF or AVL or AVR, so they have their own signals. If we talk about V1, V2, V6, they have their own signals. Own signals means at this spot, this is the intensity of the signal, and that is not what we say, that is not affected by the other lead signals. Okay, so this is like there are 5, 6 ranges: one range, 2 range, 3 range, 4 range. So these signals are spotted only here, and these are not influenced by this site. Okay, so that's why they create or they generate the specific combination of the waveforms. Okay, specific combination of the waveforms. This lead is generating the specific type of the wave, and that is unipolar. Unipolar means it is not affected by other leads. But when we talk about RA, LA, and LL, that means this is affected by other leads also. When we are keeping RA, okay, I mean RA and LA, so those two are affecting their own in either it is 3-lead ECG, either it is 12-lead ECG, either it is 5-lead ECG. LA, RA, LL, and these RL, those are influenced by other leads as well. Those are influenced by the other impulses as well. Okay, because these are away from the heart, and there are the mix-up. What we call it, there is the mix-up of the signals. There is the combination of multiple signals. Okay, there is the combination of multiple signals. That's why 3-lead ECGs have the lesser, what we say, efficacy. Okay, or lesser validation. 5-lead ECG has a little more validation, but the 12-lead ECG has the validation or efficiency around 80 to 90%. But 3-lead ECG has around 65 to 70%. 5-lead ECG has around 75 to 80% efficacy, because we don't get the perfect electric signals. okay, we get the combined electric signals. We get the electric signals which are affected by each other only, which are affected by the other signals as well, other impulses as well. In this area, we don't found only unique, impulses, but those impulses are mixed, right? That's why we call them bipolar leads, like, because these are affected by others. So these generates the waveform combinations which are affected by others as well, right? So that's why these leads are called as bipolar leads. And three electrodes or 5 electrodes usually generate the bipolar leads. And 12 lead ECG has the specific bipolar leads as well as the unipolar leads as well. So to get the best results, place electrodes on the chest wall equidistant. Again, as I was talking about the equivalent distance between the leads, right? When you have the equivalent distance from the leads, then they will equalize the impulses, okay? And there are the high chances of specific results. That's why we should always keep the equidistant between the leads. So these distance, how we find out that it is equidistant or not? Check the sternum area. From sternum area, check the distance. Here, look at this. This is equidistant. Okay, when we keep 5 lead ECG, one lead will be here and one lead will be here. And so from this sternum lead, these all leads will be at the same distance, So the impact of the other impulses will be same at all 4. Okay, so here in that we get a higher chance of getting the the perfect results. Okay, so that's 3 lead ECG, and the 3 lead ECG looks like this. So this is bipolar leads 1, 2, and 3, right? Then let's go to 5 electrode ECG or 5 lead ECG. So 5 lead ECG, as I told you, RA, LA, RL, LL, and this V is at the mid of the sternum. That is again the equidistant. So it is not here, it is here actually. So it has the equal distance from RA, LA, LL, and RL. Okay. So here 5 electrodes, RA, LL, LA, LL, and chest. So monitor displays again bipolar leads 1, 2, 3. Okay, and a single unipolar lead that is the position of this lead, again the sternum leads, wherever you put. So with this influence, again you can change it, but usually it is equidistant if you want the perfect results. But if you want to check, like in certain cases, like heart attacks, in certain cases like myocardial infarctions, you can just push it a little up and down, in the different intercostal spaces to check where the impulses are high, where the impulses are restricted, where the impulses are broken, where these impulses or signals are damaged. To check that, you can change the positions and check the different ECG waveform combinations. Okay, so this is a 5 lead ECG. This is a 5 lead ECG. So there are 1, 2, 3 unipolar, then AVR, AVL, AVF. I mean, all 12 combinations are here, but usually there are 3 unipolar and 1 bipolar. That 1 bipolar, you can just change the situation, change the location of that, the mid-sternum lead, and you can keep it at any place and check the leads. So it is actually, it is getting all the impulses, and it is creating all 12 waveform combinations. Now 12 lead ECG. So this is a 12 lead ECG. As we have seen, there are like 10 electrodes. So 10 electrodes, one is right arm, right leg, left arm, left leg, then V1, which is parallel to V2, then V3, then V4 at mid-clavicular, then marginal axillary, and then mid-axillary 6, right? So 10 electrodes required to produce 12 lead ECG. So there are four electrodes on 4 limbs, and then select 6 electrodes on the precordium from V1 to V6. As we can see here, and then it registers all the impulses from 12 leads. So here we can definitely easily identify which is bipolar, which is monopolar, because monopolar like unipolar. So bipolars are these always RL, RA, left, and LL and LA, and these are unipolars because these are now collecting the different individual impulses or signals. Okay, so here, as we can see, the most useful lead is V4. Most useful lead is V4. Okay, here this is because this is at the mid clavicular line. Mid clavicular line here you can see at between the fourth and fifth intercostal space, mid clavicular line, and it is showing the sensitivity of 88% and specificity of 78%, and diagnostic accuracy of V4R is 83% for MI. So usually if we look at the look at V4 is the major to check. Okay, V4 is major to check, which shows the differences, and we can easily identify the MIs. Okay, so this is the grouping. This is 1, 2, 3. These are unipolar leads, and these leads, like first is lateral, second is inferior, and again third is inferior lateral. Okay, why? Because these three are different at the different positions. Okay, again if we check about the AVR, AVL, AVF, so these you want to see what is AVR, AVL, AVF in the leads or in the electrodes. Why? Because these are the reciprocals. I'll not say, these are the mirror forms of these unipolars. Okay, AVR, AVL, and AVF are the mirror forms of 1, 2, and 3. Okay, guys, these waveform combinations are the mirror form of 2, 3. Remember this. Okay, and these are also known as the reference waveforms. Okay, and based on that only we compare 1, 2, 3, and we diagnose whether it's a problem or not. Okay, understand? So AVR, AVL, AVF are the mirror form of 1, 2, 3, and 1, 2, 3 are the bipolar leads, not unipolar, bipolar leads, which are coming from left limb, right limb, thumb and lower limb, left leg. Okay, usually. And this V1, V2, V3, we have seen these are the precordial leads. So V1, V2, V3, and V4 shows the anterior of the heart. Anterior part of the heart means the apex side and the anterior part. If you look at the positions of the heart, so first is apex, then the anterior. Anterior means the upper part. Posterior means the downside part of the heart, right? Downside of the part. So it is based on there is the anterior posterior, which is the left, which is the right side inside the heart, right side of right side of the heart, but inside, not the outside, looking at the chest, right? So there are the different positions and different locations in the heart of the heart wall, which shows that whether it's a posterior region of the heart or anterior region of the heart. So anterior region is shown by these V1, V2, V3, V4, and inferior regions are shown by V5 and V6. Okay, and again V8, V9, V7, that is also known as V7, are the mirror forms of V4, V5, V6. Okay, people, they say, this is not reflected in ECGs. Okay, this is not reflected in normal ECGs. V7, V8, V9, or V7 is also known as V4R, are not reflected in the normal ECG strips, but these are again the mirror forms or the references for V4, V5, and V6. Understand? Are the mirror forms of V4, V5, and V6. Similar to AVR is for A, AVR is for 1, AVL is for 2, AVF is for 3. These are also the forms of 1, 2, 3. So similarly, V7 or V4R, V8, and V9 are the mirror forms of V4, V5, and V6. So this is the grouping, and based on these only, we always define the type of MI, right? So now, guys, tell me how to calculate the rate from a ECG. Tell me how to calculate the rate from a ECG. I have only 20 minutes to teach now, and there are a lot of slides now. Almost many, because I have to leave to the airport also in some time. So tell me what are how to check the rate. Achha, what is heart rate? And how it reflects in the ECG. Okay, look, I'll tell you. So see, heart rate, there are the formulas. Okay, one is from the large squares, one is from the small squares. So first of all, look at this. I mean, in any ECG forms, also in the normal ECG here, in the 12 lead ECG. So here if you look, from one P to another P, okay, we usually don't see between the P's, we see between the R and R. Okay. This is QRS complex, this is QRS complex, right? This is the QRS complex. So in the QRS complexes, between the QRS complexes, the space, the distance between R and R, that is known as R and R interval, RR interval. Okay. So the boxes, you can see the boxes between R and, so see, one box, two box, three box. I mean, majorly these are the big boxes, but inside this also, in the ECG graph, you can see there are another mess. This big box is also looking like a mess. So there are some small boxes as well inside this. Okay, so the distance between R and R and the number of boxes between R and R are actually helpful in calculating the heart rate, okay, from the ECG, right? So let's discuss that here, how to calculate the rate from ECG. So as I was telling, R and R interval, okay, this is R, this is R. So between these are, how many large boxes are there, how many small boxes are there? This is a large big box, okay, this is a large box. This is called as a large box. And in one large box, there are 25 small boxes. Okay. In one large box, there are 25 small boxes. So there are 5 rows and 5 columns. Okay. So 5 into 5, 25 small boxes. So the distance from this side of the big box to this side of the big box, there are 5 small boxes. 1, 2, 3, 4, 5. Okay, one big box, 5 small boxes. So overall 25 small boxes, but one row, 5 small squares. So one small square, this one small square is known as 1 millimeter. Okay, and 1 millimeter is known as 40 milliseconds, 0.04 second. 100 millisecond is 1/10 of the second. 100 milliseconds, that is 0.1 second. Okay, but this small box is not even 0.1 second. This is just 0.04 second, that is 40 millisecond. Okay, so if the one small box is 40 millisecond, then how much is the big box? 0.04 into 5. So one big box is 0.02 second. That means the 0.02 second means 200 millisecond. So big box means, big square means, a large square means 200 ms or 0.2 second, and small square means 0.04 second or 40 millisecond. Okay, so 1 second is equal to 5 big boxes, right? From here to here, 25 mm, because one big box, 5 mm, 5 small squares, like one small square is 1 mm. So 5 small squares, 5 into 5 small squares make 1000 millisecond, and that is equal to 1 second. Understand? So 5 large squares make 1 second, 5 small squares make 0.2 second, right? And 1 small square makes 40 millisecond. So if in the seconds, 0.04 second, 0.2 second, and then 1 second, right? So what is heart rate? Okay, what is heart rate? As we can see here also, one small box is 1 mm, one big box is 5 mm, because one big box has 5 small boxes, right? 5 small squares, correct? So the heart rate calculates always based on the number of boxes between the R and R interval. This is R and R. So distance between R and R is also known as RR interval. So how many big boxes are there? Suppose one full big box is there, another full big box is there. Okay, and we can see this is also almost one big box. So there are three big boxes. Okay, there are three big boxes between R and R. Okay, if you cannot make out that how many big boxes are there, then always count small boxes. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So definitely 15 small boxes, 15 small squares is equal to 3 large squares. Understand? Small squares 15 means 3 large squares, because one large square has 5 small squares, right? So that's how we have to count. It does not mean that if we count that 15 small boxes, that heart rate is 15. No, there are the formulas. Okay, so based on big boxes, if we want to calculate the heart rate based on the big boxes, then we have to divide 300. We have to divide 300 by the number of big boxes. If we want to calculate from the small boxes, then we have to divide 1500 from the number of small boxes. If we are calculating by 300, then by 3, heart rate is 100 here. Okay, heart rate is 100 beats per minute. And if we calculate from small boxes, in 15 small boxes. So again, heart rate is 100, small or large. Heart rate is 100. Okay, so look at this. Look at this. I think I missed out. Where did I miss out? I'm so sorry, guys. Okay.
Right now you're audible, sir.
So here, I think we were here on right.
Yeah, right now you're audible. You were out for a second.
Which slide? On which slide?
It's still not visible. Your slide is not visible.
Now?
No, sir.
Wait. Okay, wait. I'll just share it again.
Right now it's visible, sir.
Now?
Yes, sir. It's visible.
Okay. So we were at this only. Okay, we were talking about the large square method to check the ECG rate. So if we look at him, I mean, look at this segment, RR interval, R and R, this R and R, only one large square is there. Okay, so when we are talking about large square, we have to calculate the number of large square. Okay, we have to divide 300 by the number of large square. So only one large square, 300 divided by 1 is equal to 300. So heart rate is 300 beats per minute. Between this and this R, between this R interval, RR interval, there are two large boxes. Okay, two large. So 300 divided by 2, 150 beats per minute. If we talk about this R and R interval, this RR interval, there are 3 large boxes. Okay, so 3 large boxes means 100 divided by 3. 100 beats per minute. If we look at this R and R interval, that means there are 4 large boxes. So 300 divided by 4, 75 beats per minute. If we look at this, we can calculate heart rate very easily. So there are 5 large boxes between R and R, between one R and R. not the entire RNR. One RNR, there are 5 boxes. So the heart rate 60 beats per minute. So the formula is large RR squares would be dividing 300. Okay, so before calculating it in beats per minute, we should understand okay, so that's not important. The formula is, if we are talking about the small boxes, then we have to divide 1500. If we are talking about the large boxes, we have to divide the 300. Okay, so now this is the small box, small square formula. Again, same thing. Large square 300 by 1, 300 BPM. But if we talk about small squares, now there are 5 squares, right? One big box is equal to 5 small squares. So 5 small squares, we have to, like divide it 500. I mean, dividing 1500 by 5, number of the small square. 1500 divided by 5, 300 BPM. Either you go with large square method or small square method, the heartbeat will come same only, whether it is you check by square, a small square method or large square method, the formula will calculate the same heart rate only, right? So similarly, here there are 2 big boxes, means the 10 small boxes. So 1500 by 10, 150 BPM, beats per minute heart rate. Here 1500 divided by 15 means 3 big boxes, 15 small boxes. So your heart rate is 100 beats per minute, right? So when you are talking about small squares, you have to divide 1500. When you are talking about large squares, you have to divide 300 by the number of large squares, and 1500 divided by the number of small squares. Okay. Now examples, and you guys have to tell me the heart rate here. Guys, tell me the heart rate. Calculate the heart rate. You have 30 seconds to calculate the heart rate. Calculate the heart rate and tell. You apply small square, big square, anything. Okay. So this is for your information. Let me put the pointer again. Okay. This is RR interval. Whether you take this or this is RR interval. This is again RR interval. This is again RR interval. Take any RR interval and calculate the heart rate, and tell me what is the diagnosis. So let me tell you, diagnosis here would be either bradycardia or tachycardia. Tachycardia when the heart rate is more than 100 beats per minute, and tachycardia when the heart rate is lesser than 60 beats per minute. Okay, so you calculate me the beats per minute and tell me the diagnosis, whether it is tachycardia or bradycardia. Tell me, guys. $85. Okay, Tausif is writing 85. Okay, 85. Cool. So this is a normal ECG. Okay, another one, someone else, 75. Omika is telling 75. Darshan is telling 75. Okay, so according to you, this is a normal ECG. Perfect. This is a normal ECG. Okay, this is a normal ECG. Heart rate will show later. Now tell me about this. Calculate the heart rate here. Calculate the heart rate, guys, here, and tell me what's the diagnosis. Definitely bradycardia. 50, is it? Okay, bradycardia. Yes, bradycardia. What was the heart rate? Okay, let's check the heart rate of the first ECG. 75 beats per minute, perfect. Second ECG, 37, 38 beats per minute. Absolutely fantastic, guys, amazing. Yeah, 38 beats per minute. Now tell me about these two. Calculate the heart rate by these two and tell me the diagnosis, guys. Okay, Urmisa, is 125 for the first one. Okay. Okay. Second one. Okay, Darshan, you're talking about first one, right? Okay, guys, tell me the second. $300. Okay, so you're telling these both are tachycardias. Both are tachycardias, right? Okay, I understand. I got the point that these both are tachycardias. But is there any specific difference in these two ECGs? T wave. Is it a T wave or P wave? See, there is no P wave. Okay, first of all, and the waveform is too soft. This is not ST elevation. This is called supraventricular tachycardia. Okay, so different. We see all the waveforms P, Q, R, S, and T. But here there is P, there is no exactly T to differentiate. So this form is called supraventricular tachycardia. That means, okay, so this is the condition, guys. This is the what happens usually. The impulses or the the charges, the impulses are not collected by the these are just spinning in the atrium and re-entering to the SA node. Usually what happens, the impulses are generated from SA node, spinning inside the atrium and caught by the AV node. But here AV node is not working. Okay, AV node is not working properly, and if it is working also, it is working wrongly, and it is not properly collecting all the waveforms. It is not collecting all the impulses, and the remaining impulses are re-entering, making the re-entry. That is called re-entry of the waveforms, re-entry of the impulses to SA node, and re-entry into the different zones of atrium, right atrium and left atrium, right? Because these two atriums share the septum also, right? So that is called the re-entry of the impulses. So re-entry of the impulses is very high, and these impulses are actually not going to the downside after AV node. So that means they are re-entering to the SA node, and the super part, the our part of the ventricle, our part of the the ventricle is not functioning well. Our part means the AV node, actually the triangle of Koch, okay, that is not working properly. So these problems are generated from there. Okay, re-entry is generated from there. Re-entry generated from there means AV node is not working well. So those waveforms are just spinning and re-entering to the SA node. Okay, so that is called supraventricular tachycardia. Tachycardia, why it is tachycardia? Because the delay is now not of 0.1 second when the entire atrium is getting emptying, but there is no delay and there is no contraction of the atrium. Okay, so that's why there are the high heart rate, and heart rate is very high. Very high means like 300, 400, 500. Okay, so these are known as supraventricular problems, supraventricular tachycardia. This is normal tachycardia, sinus tachycardia. Sinus tachycardia, why it is because sinus is well, but this is affected just by the autonomic nervous system, whether because of exercise, heart rate is raised, but because of the other conditions, not because of the sinus node re-entry. Okay, this is because of the sinus node re-entry. Okay, sinus node re-entry. Okay, this is because re-entry. There is no wave. Okay, so this is called supraventricular tachycardia. This is called normal sinus tachycardia. So this is sinus tachycardia. This is supraventricular tachycardia. Okay. Heart rate first was around 150, 140. The second is around 300 beats per minute. Okay. So based on that only are the tachycardias. So some are narrow QRS tachycardias, some are broad QRS tachycardias, bradycardias also. So broad, the narrow QRS tachycardias are usually supraventricular. Okay. So as you can see here, this is very narrow, means there is no P and T wave. Usually there is no P wave. P wave is not there. And QRS means QRS is quite, this is ventricular tachycardia. So supraventricular tachycardia means the above part of the ventricle is involved, means the atrium is involved in that. Supraventricular means not exactly ventricular tachycardias, not generated from the part or septum of the ventricle, but these are generated from the atrium. As I told you, atrium was completely involved, spinning in the atrium, and re-entry was there into the SA node. But when we talk about the ventricular tachycardias, means these are generated from the ventricle, means AV node functioning, but the re-entry is at either at the His or at the Purkinje fibers. Okay, bundle of His, or there are the bundle blocks, or the bundles are damaged. Okay, so the tachycardias or the arrhythmias are generated after the AV node in the ventricular part, in the ventricle septum. Okay, so that's why these are called ventricular tachycardias, and the rate is usually lesser in the ventricular tachycardias and rate is super high in the supraventricular tachycardias, because there is the re-entry. There is the re-entry of the impulses into the SA and AV node only, in the atriums only, right? So this is broad QRS tachycardia. This is narrow QRS tachycardia. Okay. Example 3. Now tell me what is this? Make out P wave here or T wave? What is this ECG, guys? Okay, I'll give you the clues of irregularly rhythm. Rhythms are irregular, but this irregularity is also irregular. Regular irregular rhythms are when this waveform combination is similar in all the waveforms. Okay, see, this is one waveform combination. This is another waveform combination. This is another waveform combination. So when, I mean, definitely it is irregular, but this would be same in all the combinations. Okay, the same pattern will be in the other combinations as well. So that is called irregular rhythm. Rhythm is irregular, but the pattern is same. But when we call it irregular rhythm, that means the rhythm in each combination waveform is different. See, look at this. This is different than this. This is different than this. This is different than this. Here only 2 waves. Here 5, 6 waves. Here 6 waves. Here 5 waves, 4 waves, 3 waves. And the distance between RR is totally different in all the waveform combinations. Okay, like in one waveform, in one, if we say one lead, in one lead there are usually 3 waveforms, the combination of 3 waveforms. Okay, one rhythm, that is called one rhythm. Okay, lead is one rhythm. So in one rhythm there are 3 waveform combinations, and all 3 waveform combinations are same. But here if we look at any 3 waveform combinations, the rhythms are, I mean, in one rhythm these all 3 waveform combinations are different. Okay, different. So that is called regularly irregular rhythms. MI, arrhythmia, this is arrhythmia only. MI, atrial fibrillation. How can you make out atrial fibrillation? Tell me. Okay, so I'm giving you the clues. Check out. Irregular rhythms. Okay, no P waves. Of course, there's no P wave. Can you see? Is there any P wave? No P wave. See, here also no P wave. Here also no P wave. This is the extension of T and U wave. There is no P wave. This is directly starting off QRS complex. Here also starting off QRS complex, no P wave. See, here also no P wave, only starting off QRS complex. See, anywhere you can see there is no P wave. So usually, where did you see that there is no P wave? Okay, another formula I will say, another this absence of an isoelectric baseline. So what is isoelectric line? The baseline, okay, the straight line. There is no isoelectric baseline. See, if I say this is the isoelectric baseline, there is no isoelectric baseline. All the waveforms trend either down, either up, down. Some are up of wave 5. You know, wave isoelectric waveline. Okay. So there is no isoelectric waveline also. The straight line is not there for any waveform combination. Okay. Other than that, variable ventricular rate, definitely there is no ventricular rate proper. RR intervals, there is no proper rate. Okay. Then QRS complex is more than 120 ms unless pre-existing bundle block. So these are the combinations, these are the clues going for atrial fibrillation. So when there is no P wave, when there are irregular rhythms, there is the absence of isoelectric line, you can straight away tell atrial fibrillation. And there is the variable ventricular rate in every RR interval. If there is a different rate for continuous 3 RR intervals, then you can say it is atrial fibrillation. Okay, atrial fibrillation. What is there? Irregular rhythm, no isoelectric baseline, no P wave, variable ventricular rate. It is atrial fibrillation. Last thing I want. So tell me what is this, guys? Tell me what is this? This is very easy to make out. Here you can see. You can make the diagnosis very easily here. Okay, look at this. Take just 5 more minutes. That's all. Getting late. See. Look at V4. This. Look at this. Look at this. What is this? What is this, guys? What I'm pointing out. This is T wave inversion. Exactly. T wave inversion. That means the myocardial infarction. Okay. So this is the patient of 55-year-old with the parental history of MI at the age of 52. So parent got the MI at the age of 52. Patient is hypertensive, hyperlipidemic, and hyperthyroidism. Okay, and you can see TC levels, LDL levels are 236, creatinine levels are 1.4, now almost right, just raised. And if we look at the troponin T, it is 10 times higher than the normal. And CKMB are normal, CKMB are normal, but troponin T is very high. So this is MI. Okay, sinus rhythm with small Q waves in lead 3. If you look at this small Q wave, there is no Q wave actually. When a small Q wave in lead 3 and AVF and TV form, and then ST depression V5, V6. ST depression in V5 and V6. Look at this. Right? So this is called MI. Now you must be thinking like how it is. I'm just talking about the ST elevation MI. This is ST depression MI. I mean ST. So what should be the next? Here you can check what is STMI, what is an ST. I'm sorry, this was NSTMI. Okay. So what's NST? This is a normal ECG, normal ST segment. Okay. This is ST depression, what we have seen. Okay. This is ST depression, but not elevation. This is non-ST elevation MI. Means ST is not elevated. Elevated means upside. ST is going downside. ST is inverted. Okay, T is inverted and ST is depressed. Depressed means ST is going down, going downward. So that's why it is called non-ST elevation MI. This is ST elevation MI. See, look at this is the baseline electroline, right? Base electroline. So base electrical line, this is going upward. The ST segment, entire ST segment is upwarded, entire ST is elevated. So this is known as STEMI, ST elevation myocardial infarction. Okay, ST elevation myocardial infarction. And this is again non-ST elevation MI, because either ST entire segment is depressed or T again only T is going down. ST baseline is normal, but T is inverted. T is going down. So that is also known as an STEMI. This is also an STEMI. This is STEMI because ST is going up. Okay, so that's how we differentiate the normal ECG, STEMI and STEMIs. Okay, guys. So this is the normal part of ECG learnings. And if we talk about stable anginas, usually normal ECGs, but small plaque. And why small plaque? Because this goes for longer time and blood flow is half or a little more than half. But it is like sometimes angina is occurring. Okay, angina is not every time. Infarct is not there. Okay, plaque is there, but infarct is not there. So your ECG will be normal. In unstable angina, there will be no infarct, but there will be supply ischemia. Supply ischemia means the plaque is a little more and just what we say, the typical anastomy type, usually T waves are inverted or ST is depressed. Okay, here you can see ST is depressed, T waves are inverted, but this is unstable angina. Okay, but when we talk about anastomy, means the T wave is 100% inverted or the ST is totally depressed. Okay, and there is subendocardial infarct as well. So infarct means there is a clot as well. Now, previously it was not clot, it was just plaque. Okay, but plaque is ruptured and now thrombus it has hyperacute. So like T wave will be inverted upward or ST is elevated complete. Okay, and there is again the transmural infarct. Okay, so there is again the infarct, and these three are emergencies. Okay? These three are emergencies or known as acute cardiovascular problems or ACS, acute coronary syndrome, including unstable angina, STEMI or STEMI. So in these, as soon as possible, patients should get to the hospital. And stable anginas are okay sometimes if they stretch it up because chest pain is not every day, but still in that case also patients should go and check the ECG, check the echo, and check the troponin. Check the troponin till troponins will be normal. Okay, ECG will be normal. Then they should go for the stress test, that is called as TMT or stress echocardiogram, because in the stress, ECG will change and you can manage easily the diagnosis with the TMT or stress echo. Okay, unstable angina also troponins are normal, but you can make out in the ECG, and then you can go for usually we don't go for stress tests in unstable STEMI. These are all three called as ACS, acute coronary syndrome. So with that, guys, that's all for today because we cannot understand everything in one go. I hope the basic was clear. Thank you very much. So if any questions, you can I'll be happy to take your questions for next 3-4 minutes, guys.
We move on to the question and answer session. Like if anyone has to ask sir any questions, they can either put their questions in their chat box or raise their hands so I can unmute them so you can ask your respective questions.
Yeah, anyone? Sure. And again, I would like to thank Indian Pharmaceutical Association Student Forum Pune branch for arranging the wonderful Edilon and inviting me for this. Thank you very much, guys. If it would have been the physical, the conference, then it would be quite more fun. But that's okay. So, any questions, guys? Thank you very much.
Anyone, any questions?
Any questions, guys, here?
I don't
think there are other questions. Okay. So thank you, guys. Again,
thank you, sir. Thank you for this insightful session of yours.
Thank you.
It was very knowledgeable for all the participants who have been attending this meeting. Thank you so much, sir.
Thank you, guys. Thank you. Take care. See you guys then. Take care. Bye-bye. I'll leave the meeting.
Sure. Now we move forward to our next most exciting session, Orientation to Cannabinoids by Dr. Shruti Sridhar. With so much appreciation and pleasure, we welcome you, ma'am. Dr. Shruti Sridhar is a general physician practicing integrative medicine.
Thank you. Thank you for the introduction. I'll just quickly share my screen.
Ma'am, just a minute.
Yeah.
I have to give an introduction. So, Dr.
Sure.
Shruti
Okay.
Sridhar is a general physician practicing integrative medicine. She graduated from the Maharashtra University of Health Sciences, after which she pursued a master's in public health. She was in the field of public health research for a few years before deciding to get back into clinical practice. She has several publications in prestigious journals like Lancet ID. She is trained in use of medical cannabis in 2019, after which she has been extensively integrating it into clinical practice. She's a passionate health educator and public speaker and has been working to promote medical cannabis awareness in India. So let's commence our next session. Over to you, ma'am.
Thank you so much, Vivian, for that lovely introduction. I'll just quickly share my screen. 1 second. Yeah. Can you see my screen?
Yes, ma'am, it's visible.
Okay, great. All right. So thank you for inviting me, and it's lovely to have this opportunity to speak to budding students and budding researchers, because this is a very interesting topic. So just out of curiosity, I wanted to know, like, how many of you have heard of medical cannabis and are aware of its use? You can put it in the chat box, so, or you can raise your hand, however. So you're aware of how it works, or that it's being used, and then it can be. I just want to understand what is the general awareness level among students. That's the whole thing. So you can just say yes if you know, or no if you're not aware. Okay, Jasmine says yes. Okay, thank you. And I'm sure that a lot of you must have smoked cannabis as well without knowing the science behind it. But okay, so this topic is very close to my heart because it's been a very nice journey. I mean, I'll share that sometime, some other time. Charas Ganja abstract on cannabinoids. Okay, all right. So I can see that it's not a lot of information, but you have some information. Okay, good to know. Oh, sorry. Okay. So in today's talk, I just want to brief you to what cannabinoids are and what are the research prospects and why it is so interesting and cutting edge that more and more research needs to be done in this area. And no topic of cannabinoids or cannabis is complete without introducing Professor Raphael Mechoulam. He is from the Hebrew University in Israel, and he is the father of endocannabinoid research or cannabinoid research. And he was the one who discovered the potent psychoactive molecule in cannabis, which is THC or tetrahydrocannabinol. So from there, so this happened in 1964, and from there it has been a wild journey for medical cannabis, and there has been more than maybe 30,000 publications on it, and more so in the last 15 to 20 years that the research has completely, fast tracked in that field. So what is this THC, CBD? What are cannabinoids? What it is? So before we get to that, we need to understand the basic plant anatomy. So cannabinoids are certain molecules that are produced by the plant cannabis for its own protection. So it's something that the plant produces to prevent itself from being eaten by predators, preventing itself from, the insects coming there and taking the seeds away. So it is basically a mechanism of defense that the plant has developed. So they are formed in these, can you see this tiny white crystal like structures? So these are the structures known as trichomes, and they are present around the bud area of the plant and towards the smaller leaves at the base, which are called as the sugar leaves. And this is where the 99% of the cannabinoids are produced, so because they are protecting the seed of the plant. The flower and the bud, and the flower which later on becomes the seed. So the entire reproductive part of the plant is being protected by the trichome, which produces cannabinoids. And this is only present in the female plant. The male plant has barely anything. It has got like very little percentage of cannabinoids, and that's not of great interest for us because we cannot even extract a lot out of them, right? And as you go further down, you have these bigger leaves which are called as fan leaves. Again, the concentration of cannabinoids start decreasing as we go down. So the most potent part of the plant, which is the trichome, that is where the cannabinoids are produced in majority. And this they identified in 1964 that THC was the molecule which was giving the high when you smoked or ingested cannabis. Now, it is so interesting that you must have heard of opium, right? Opium is another plant from which we extract morphine, and it's one of the most potent drugs that is used for pain relief, especially in cancer pain and severe chronic pain. And the structure of morphine and the isolation was done 150 years ago. But we came to know about cannabis only in the last 50 years, that okay, this is the reason we get the high when you consume the plant. So it's a very recent finding, I would say. So we have a long way to go till we integrate it into our system, into the medical knowledge as well, and as well as into the clinical practice. So along with cannabinoids, there are few other classes of molecules that the plant also produces. One major one is called as flavonoids. Flavonoids are basically flavone compounds, like you must have heard, and many plants produce this. Like one very common thing is soy isoflavone, which is present in soya. And they all are basically a certain structure which is called as flavone, and they have certain properties, and a lot of plants produce this. That is one. The second set of molecules that they produce is terpenes. So terpenes are compounds which give you a distinct flavor, like if you know the taste of lemon, right? It's produced because of a terpene called as limonene. And the distinct flavor of pepper, black pepper, that is because of beta caryophyllene. So these are certain compounds which give that particular flavor to the plant. And so flavonoids, terpenes, and cannabinoids are three major classes of compounds that are produced by the cannabis plant. And within the cannabinoids, you've got I think now they have isolated more than 50 types. So you have CBD, you have THC, CBDA, THCA, THCV, CBG, CBN. There are like loads of them that they have isolated. And the thing is, the percentages of these compound, they vary from strain to strain. Like if you take the Indian strain, for example, which is Cannabis indica, which is commonly found, it is very high in beta caryophyllene. So it will be like little peppery to taste, and it will be higher on THC compared to CBD. So like that, every strain has its own properties and its own flavor, to add to it. So this is the what you can say, the entourage of compounds that are created by the plant. And this is becoming more and more relevant to the medical fraternity, because we are realizing there has been only very few papers addressing this, but we are realizing that the medical property of the plant is not because of one compound or one molecule, but it's because of the combined effect of all of this. And this is called as the entourage effect, which is why when they tried to give isolated molecules, when they gave isolated THC. There was a study in which they were giving isolated THC molecules to see pain relief. They saw too much side effects. They had to stop the study. But at the same time, when you are giving the entire plant extract along with the flavonoids, terpenes, everything intact in it, the side effects are much less. So somewhere these molecules, they kind of interact with each other, help reduce the side effects, help increase the medical effects of the plant itself. So, and let me tell you, since I am talking about the history of that, because it's very interesting. Can anybody guess when was the first receptor discovered? Like receptor ligand, we talk about a lot of receptors and ligands. So when was the first receptor discovered? Does anybody have any idea? Anybody? No? Okay. So the first receptor was discovered somewhere in 1948, I think. And that was the adrenergic receptor. And then there were serotonin receptors that were discovered. Then the opioid receptors were discovered. And until 1994, they had no idea how the cannabinoids were acting in our body. They knew, okay, there is CBD, there is THC, there are these compounds, but how were they interacting with it, with our body? They had absolutely no idea. So because we didn't know this, we did not understand how to utilize this in a therapeutic manner, because we didn't know their pharmacokinetics and how it actually performed. So that was a very big block that was there in this thing. So in 1994, the cannabinoid receptors were first discovered. One was called as CB1, and then a sister receptor was discovered called as CB2. And then slowly, they started discovering the ligands that were acting on these receptors, So they found the first ligand, which was AEA, also called as anandamide. And it was called as anandamide because it produced ananda or bliss. So it was labeled as anandamide. And then there was 2AG. And then slowly, the literature began to grow about this. So did you know that we all produce cannabinoids in our own body? So as I said, we have the cannabinoid receptors that were discovered. And then we discovered the ligands. So these ligands, they act as endogenous cannabinoids. So they work on these cannabinoid receptors to produce same effects that the phytocannabinoids or the plant-based cannabinoids like CBD and THC produce in our body. But the interesting thing is, if you see the chemical structure, Anand, this is anandamide, which I just mentioned, which is our endogenous cannabinoid, and this is 2AG, the two most common endogenous cannabinoid in our body. This is CBD, and this is THC. So the endogenous cannabinoids have very different structures compared to the phytocannabinoids, and even their the parent molecules from where they are made is very different. But the interesting thing is, even though they are structurally very dissimilar, they have similar effects when they turn the receptors on. So when they get attached to these receptors, CB1, CB2 receptors and the others, they have similar physiological effects. So any molecule which can attach to these receptors and are producing these kind of effects are termed as cannabinoids. And if they are produced by our body, they are called as endocannabinoids. And if they are produced from the plants, they are called as phytocannabinoids. And if they are produced in a lab in a synthetic fashion, they are called as synthetic cannabinoids. So that's how the major division happens. Okay, so the understanding of cannabinoids will not be complete unless we understand what the endocannabinoid system is. So that is where the entire plant acts. The cannabinoid, the phytocannabinoids as well as endocannabinoids, they act on the endocannabinoid system. This, even though it is one of the most ancient cell signaling system, it was discovered in the late 1980s or early 1990s. That's when the CB1 and CB2 receptors were discovered, that's when they knew, oh, there is something called as endocannabinoid system. So like we have our adrenergic system, we have our serotonin system, we have our dopamine system, we have something called as the endocannabinoid system. Now this system is a cell signaling system, which means that this is the way these cells communicate with each other, and this is more, it functions as a negative feedback mechanism, and it is one of the most ancient systems because phylogenetically, like if you go back in time, even the vertebrates, the smaller vertebrates, the ancient organisms, even they have even identified a very rudimentary form of this endocannabinoid system in Hydra, which is like the single cell molecule, you know. So right from the single cell molecule, this system has gradually evolved, and it has stayed through the test of time. So definitely it means something. It has some value in our body. Otherwise, we would have lost it. Like we lost so many other things, you know, in our evolution. We would have lost it, but we didn't lose it, which means it plays a very important role. And that role is maintaining the homeostasis in the body, homeostasis within the cell, as well as homeostasis around the cell. That's very, very important. And the third and very interesting characteristic of the system is that it's created on demand. So when it's required, the receptors, CB1, CB2 receptors upregulate. When the demand is low, they downregulate. And you know, it's a very dynamic system. And that is why it was so difficult to discover it, because they could not isolate the anandamide and 2-AG molecules. They were so less in quantity in the blood that it was very difficult for them to isolate it. So the CB1 receptors are mainly found in the brain and the spinal cord and the nervous system. And the CB2 receptors are mainly found in the immune system, although they are distributed in all other organs also, but mainly they are found in the immune cells. So the lymphocytes, in spleen, in thymus, even in the brain, the astrocytes and the glial cells have got the CB2 receptor. So this is a broad definition of how they are distributed. But gradually, we are now understanding that CB1, CB2 is only part of the endocannabinoid system. The ECS, which is here, it is made up of all of these receptors, and more we are still discovering. And some of these are nuclear receptors. So they influence how the DNA is expressed, or what epigenetic changes should take place. All these things are said are, they are controlled by these nuclear receptors, and one of which is PPAR, which is written over here. So these receptors, the endogenous endocannabinoid molecules, we have isolated more than, I think, 100 of them, which are there in our body, and the enzymes which make it and disintegrate it. So all of these together today form what we know as the extended endocannabinoid system. So it is a very huge thing, as you can see, and it's very complex, but at the same time, it's very interesting when you start, reading about it. So this is just a quick description of how the cell-cell signaling actually works. This is called as, the term is called as retrograde signaling. So I'm not sure if it has been covered in your syllabus, because I don't teach any pharmacy students. But just in very simple terms, what it does is, let's say there are two neurons which are communicating with each other. So neuron A is trying to communicate with neuron B here, let's say. Okay, so wait, here. So this is the terminal of the first neuron, and this is the dendrite of the second neuron, and they are trying to communicate with each other. So what these endocannabinoids do, once this neuron is triggered and it excites the postsynaptic neuron, the endocannabinoids, like you can see 2-AG, is released. It goes back to the first neuron and asks it to stop it. It says, enough. You have been excited enough. Now I want you to rest. So this is the negative feedback that the endocannabinoids give to stop excessive excitation of stimuli. So this is the way it maintains the cell-cell homeostasis or cell-cell communication. Okay. Now, what are the different things that the endocannabinoid system regulates via this mechanism that we discussed? The first and the most important thing it regulates is sleep. The diurnal cycle, the melatonin secretion, the NREM and the REM sleep cycle, all of that is controlled by the endocannabinoid system, which is why medical cannabis works wonderfully for insomnia and broken sleep, disturbed sleep, inability to fall asleep, waking up too often during the sleep. So all these different complaints can be addressed by cannabis. The second major thing it regulates is appetite. So how much you feel hunger, how much you feel full, how is your metabolism, all that is regulated by the ECS. The third thing is digestion. The peristalsis movement, as well as mainly the peristalsis is what is regulated by the ECS. The fourth and a very important aspect is immunity, because we just now I said the CB2 receptors are present in all the immune cells, so it controls our immunity, and we are seeing more and more uses of it in autoimmune conditions, especially rheumatoid arthritis, SLE, lupus, where it works like an immunomodulator. Even in cancers we are seeing that it is having a very crucial role in stimulating the immune response against the cancer cells. So which is why it has been now trialed for cancers as well. The fifth and one of the major effects that cannabis has is euphoria. So by euphoria, it means the ability to feel joy. The clinical term for this is actually hedonia, which I said, it is the ability to feel joy. So when this goes away, when this euphoria goes away, that is when people start going into depression. So it is one of the major things that it regulates is your mood, your feeling of pleasure. And the next two major things that it does is it helps in neurogenesis, that is producing new neurons, and it also helps in protection of the existing neurons as well. So it is being extensively used for stroke patients, patients with dementia, Alzheimer's, where the brain volume is reducing. Even in demyelinating disorders, it is being used. And the next two things is learning and forgetting, which is why it's being used for PTSD, that is post-traumatic stress disorder, which is in which you remember unpleasant memories, and which causes anxiety and panic attacks and etc. So it is helps to forget those memories as well, which is also very important. We need to forget things so that we can move on in life. So as you can see, most of our primal systems in our body, or primal mechanisms in our body, are regulated by the endocannabinoid system, which is why when you modulate it using medical cannabis, there is a beneficial effect that we are seeing. So what are the other things which can help stimulate your own body's endocannabinoid system? Is cannabis the only way? Absolutely not. Absolutely not. There are a lot of other things which stimulate your body's endocannabinoid system to produce your own cannabinoids, which makes you feel very happy, makes your appetite good, sleep good, and all of that. So other than cannabis, the one major thing that helps is omega-3 fatty acids, which are there in hemp seeds, flax seeds, chia seeds, walnuts, sardines, eggs, because omega-3 is one of the substrate for forming the endocannabinoids. So once you have a lot of omega-3, your body automatically produces more endocannabinoids. So that's one. Cocoa powder also, or chocolate as you know it, it also increases your endocannabinoid tone. There are certain herbs like echinacea, turmeric, green tea, which also boosts up your body's own endocannabinoid system. And lastly, regular exercise, yoga, meditation, hanging out with friends, going out for nature walks, just having sun exposure every day. All these basic things can also boost your endocannabinoid system to make you feel good. So that also can be done without taking any cannabis for that. So coming to the different aspects, so what, just recapitulating all that I have covered in terms of research. So the first major research I think needs to go into the endocannabinoid system itself, because it is a very fascinating subject, as you might have felt when I spoke. And there is a lot to be discovered. There's a lot to understand, lot to unpack. And the research on ECS is just beginning, because the receptors were identified in 1994. So it's been barely 20, 30 years down the line. So research on that is something which is very, very crucial and needs to go. Also understanding the impact of ECS on different pathologies and different diseases, so how why like for example in anxiety, what happens for the endocannabinoid system in anxiety or in depression or in cancer. So when you understand the interaction, it's better to treat, and you can produce target therapies, you can produce specific protocols for treating as well. So right now we are missing all of that. So there a lot of it is I would say uh, I don't want to say guesswork, but a lot of it is based on animal studies and in vitro studies, not human studies and clinical trials. So that is the link that is missing, and that should be taken forward in the form of research. The second major aspect of research is phytocannabinoids, that is understanding CBD, THC, all the other cannabinoid molecules and how they actually act on our body. Even though we know that okay, THC is acting on CB1 receptors, CB2 receptors, it's doing this, it's doing that, we still don't know exactly how it works. Like, why do you get the high when you consume cannabis? So which system is getting triggered? Only very recently they found out that it's probably because of dopamine release, that the high and the kick is what you get after you smoke cannabis. But again, the research has just started and we just know the information now. We don't know whether it's been validated. So understanding how the phytocannabinoids interact with our body is the second crucial area of research, and that needs to be done. The third and probably the most interesting thing, but unfortunately in India it's still not legal, is growing and extraction. So this is a huge science in itself, because in countries where they have legalized cannabis and legalized medical cannabis and all of that, they have also permitted genetic manipulation of the strains. So what they are doing is they are deliberately decreasing the CBD content, increasing the THC content, decreasing the THC content. So they're manipulating the plant the way they want it to produce a desired effect. So I don't know if anybody has heard of this, but there is one strain called as Charlotte's Web. This strain became very popular because it was created for a girl called Charlotte, who was suffering from intractable seizures. She had Dravet syndrome, which is a genetic condition in which a person can get 20 to 30 seizures in a day, and it was devastating for that girl. And there was this research organization that was trying to grow this particular strain which has high CBD and low THC, and that worked wonderfully for that girl. And they named the strain after her and they called it as Charlotte's Web. And that girl lived for another, I think, 15 years or so, and she died very recently in 2022 or 2021. She passed away. But it gave that girl a lease of life that nobody would have expected her to. So this is the magic that cannabis has, provided you are able to tweak with the components. Now in India, what is happening, because you're not allowed to grow a particular strain or do genetic modification, we have to rely on the local strain, which is largely cannabis indica, with a mix of sativa. So other than that, there are, I think, more than 30 strains that have been developed so far, but in India, we only have 2 or 3 of them. And we are not able to access the other strains for their medicinal benefits. And also that this plant is so finicky, like you can, just by changing the nitrogen phosphorus content in the soil, the plant's response changes. Just by increasing the UV light, you can, stimulate the THC production in the plant. So the plant also responds very differently to a lot of things in the environment. So this is another very interesting area of research. So as far as cannabis is concerned, we have research on the endocannabinoid system, on how the plant molecules act or interact with our body, and working with growing and extraction of these plants to optimize the yield that we are getting, to optimize the medical potency we are getting, and to standardize it so that it can be used medically in a much efficient way, you know. So thank you so much for listening patiently. And you can, we have started this website called as cannabisclinicindia.com. It's mainly for educational purposes. You know, I am the one managing it. I try to put a lot of articles, a lot of new research, understanding with various diseases. So you can head there, you can get some information on that as well. So thank you. And any questions, you can put them in the chat box.
If there is any questions from the participant side, you can put it in the chat box, or you can raise your hand so that I can unmute and you can ask your respective questions.
Yeah.
Anyone?
And if anybody is interested in pursuing research in this field, I mean, please feel free to get in touch. I can, you know, we can see how, what topics can be taken up and what can be done. It's quite interesting.
Anyone, any questions, please?
Okay. I know this must be new. How much do you guys actually learn about endocannabinoid system, and anybody just can unmute and tell me? I'm just curious to know that. In pharmacy, like, do you have any portion on it, like any syllabus or any chapter on it?
Yes, ma'am.
Hmm.
Actually, in pharmacy specifically, doctor of pharmacy, we have a subject called as clinical toxicology.
Okay. Okay.
Yeah, and we basically read about like all the toxic substances, their overdose, their treatment, precautions, and all that.
Okay. So that is a very biased view of cannabis, I believe.
Yeah, only
And
one side.
yeah, and among all the pharmaceutical drugs, cannabis is the only drug in which you have maximum number of toxicology studies. So we know everything from A to Z about side effects of cannabis and why not to smoke and all that, but very little about the medicinal aspects of it. Yeah. Thank you for sharing that.
Hello.
Yeah.
Yeah, good evening, ma'am. Angelina here. I just wanted to ask, like, what kind of research can be done specifically in India regarding cannabinoids? Because I have seen very less research being done on this aspect.
Yeah.
Maybe due to the fact that it's a much sensitive topic and people
Right.
won't answer the right fact.
Right.
So, yeah, can you please guide us on how to do research on this topic?
Sure, sure. Thank you for that question. See, in India, cannabis has always been legal because it was available as bhang, and it is part of Ayurveda, and Ayush has always allowed it, but people didn't know it. And for research purposes, you are allowed to grow, procure, and use it in any lab. So in pharmacy, doing in India, the most difficult thing to do is clinical trials, human clinical trials. But everything else can be done very easily. In vitro studies can be done if you want to say identify, like for example, let's say you're working on cell lines. You can do that. There's one study which recently got published, because I know the author and what work they have done. They did it on cancer cell lines. And how was it restricting the growth of cancer cells, was it causing apoptosis, so this is what they studied in that paper, you know. And this recently got accepted and published also. But who are doing this is the companies who are manufacturing cannabis are doing this because it's in their benefit. But none of the institutions are taking it up. I don't know why.
Yeah.
So in fact, if anybody is interested, like I would happy to like come there, speak to the HOD and, you know, get something started off, because I know DY Patil was very interested. But I don't know where it went, but I had a discussion with the vice dean and he was telling me, no, this is very interesting. We have an agricultural college, we have an agricultural faculty, so we can bring it up. Like I said, you know, growing is a very big thing. What sort of fertilizers you use for the plant to grow, and what you can do to improve the quality of the yield, all these are also coming under research, and we need that right now. because the farmers in Uttarakhand and Himachal who are growing it are struggling because the yield sometimes is not good. It's very finicky. The crops die, and uske upar se excise wale will come and take half the crop and go because buds are not allowed. This is not legal. That is not legal. So then these kind of researchers will help them also actually.
True.
Yeah. You are in which college?
Ma'am, I'm in PCP itself. I'm a pharmacy intern. Pursuing my
Okay.
internship there.
Okay. All right.
So basically we have seen research on drug abuse and misuse, and cannabinoids does come in that role. But yeah, like for further future researchers, we would definitely would love to do this.
Do check out the Hebrew University in Israel. They are the front runners of cannabis research, and there is one in UK. The name is skipping my mind, but that is the second university that is doing a lot of research on cannabis, and then Canada. So these are the three places where you can actually apply for a master's, go there and get your hands dirty into the research, and they are looking for people to come and research in those areas. Or you can get some collaboration with them and start something in India as well. That will also be very helpful. Yeah.
Thank you so much.
You're welcome.
Ma'am, one more question from my side. As we are talking about cannabinoids, I already discussed with you, if you remember, about psychedelics.
Yeah.
Cannabinoids is still a taboo in India, and as I'm talking to new doctors and all psychedelics, they're like, "Where do you heard this word, and why you want to talk about it?" And we are, actually right now we are just learning about LSD also. So it's a great topic. It's like one of the most powerful hallucinogens
It
ever
is.
known. So,
It is.
like, I just want to ask, like, why is the taboo there anyway?
See, the taboo has all developed after 1970s when they started illegalizing a lot of things, starting with cannabis and then heroin, and then slowly, before that, everything was legal. Then that whole hippie movement started in US, and then slowly they started putting a ban on a lot of substances. So the thing is, you have to understand that addiction is not related to the substance. Addiction is a psychosocial phenomenon which is going to happen no matter what. So I would say we are living in a world that is addicted to sugar, that is addicted to screens, that is addicted to junk food, and nobody is banning these things. Nobody can dare ban these things. And in front of all of that, this is actually very minuscule. So the whole take on drugs and drug war and everything itself was wrong to begin with. So then that ban, when it started, it's kind of continuing from there. And now they are reversing it. They are lifting the ban in most of the countries with psychedelics and with cannabis and all of that. Yeah, that's a very good question. Thank you. Hello, am I audible?
Yes, ma'am.
Yeah. So with psychedelics, like I can talk just a few minutes about it because it's very interesting how they work. Cannabis is not a psychedelic, actually. It's not purely a psychedelic. They have still not researched on cannabis as a psychedelic, but the psychedelics that do work, like you have MDMA, you have psilocybin, you have LSD, they increase the serotonin levels in our brain, and you get a feeling of experiencing something larger than yourself. And most of the people that recover after a psychedelic trip is because they have had that experience and they are carrying it forward with them, and they don't do it again and again, because once you've had that experience, you utilize that experience to work on yourself and actually get better rather than going for the experience again. That is what I have seen with people, especially those whose PTSD has been cured with psilocybin or MDMA, or the people who are having end stage cancer. When you give them a psychedelic experience, their agony is gone. They don't fear death anymore. They don't fear their disease anymore. There's so much joy, there is so much happiness that they experience after that experience. So that is all magical, to be honest. But yeah, it's slowly coming in India. There are that's getting legalized. I can see that. It's a matter of time.
Does anyone have any other questions?
Yeah, Madhuri has asked me that I read somewhere that cannabinoids like ganja affect the brain aging more than alcohol. Okay, so Madhuri, thanks for that question. She has directly messaged me, so I think you guys cannot see it. But see, if anybody, if they say no, wish अमृत भी विष हो जाता है अगर आप ज्यादा लोगे तो, in a very short sentence. If you're smoking cannabis every day, you are smoking 10 to 12 joints for a long period of time, then yes, it does affect your brain volume. It does reduce your gray matter, which is being proved beyond the point. But here what we are talking is not recreational use of cannabis, but using it medically for something that somebody needs. Like, for example, there's this girl who was suffering from seizures, 30 seizures in a day, and nothing could cure her, but cannabis did. Similarly, I have treated people with severe pain who are addicted to opioids, and opioids was not relieving their pain. But when we switched to cannabinoids, their pain was better, their opioid addiction was better, and they were not craving it anymore. So we are looking at fixing a problem here. So I do understand that it always comes with its set of baggage. Like if you legalize it, yes, it will be readily available, more people will be smoking, all that is going to happen. But we have to find a balance somewhere in between where at least the medical use is not restricted, and the research is done, the licenses are given, the freedom is there to use it if it is required and if it is recommended by a doctor that it's going to help you. So I don't, that is why I don't promote smoking at all. Even for medical use, smoking is not good, because at the end of the day, smoking anything will produce carcinogens because it is a burning process. So that is going to affect your lungs mainly. So absolutely not. Ingestion, yes, great. I have seen it do wonders. So yeah.
Anyone else?
Yeah.
Have you received any personal questions?
No, not yet. No.
Not
That's
yet.
it. No, just that one.
Okay. So thank you, ma'am, for this insightful and knowledgeable session that you have
Thank you.
provided to us. And now I would like to call Jasmine Marwa, Education Head Office, to give the vote of thanks.
Thank you so much, Vivya. Good evening, everyone. It has been an honor to be a part of this exquisite session. On behalf of our organization, IPSF Pune branch, I would like to extend my heartfelt gratitude to our esteemed speakers, Dr. Ajit Singh and Dr. Shruti Sridhar. Sincere thanks to the President of IPSF Pune, Mr. Sutanshu Subrajit, and Vice President, Ms. Shruti Patwal, for their guidance in making today's event a grand success. At last, thank you to all the participants who made this event a memorable one. Thank you so much.
Before ending this meeting, I would like everyone to keep their cameras on to capture a special moment. Requesting all the participants to please keep their cameras on.
Kindly please switch on your cameras. It would be great if you could, because we have to, take a picture.
Done.
Thank you, everyone. Thank you. Now we can leave the meeting.